Thank you for joining the DEA Telemedicine listening session.
Good morning. For those of you who are returning, welcome back. For the new faces here with us today, welcome to DEA's 2023 Telemedicine listening session. I am extremely thankful and appreciative to everyone who has taken time out of their busy schedules to participate in person and virtually in this two-day event. I am also appreciative for those who are watching the live stream for this event from the DEA Diversion Control's website, www.deadiversion, all one word, .usdoj.gov. Let me now introduce the person who is sitting next to Administrator Milgram and Administrator Milgram herself. Administrator Milgram was sworn into the DEA as administrator on June 28th after being confirmed by the U.S. Senate by unanimous consent on June 24th. As the DEA administrator, she leads the agency of nearly 10,000 public servants who work in any one of our 334 offices nationwide. Next to her is Tom Pravosnik. Tom is a career diversion investigator with 34 years of public service, I believe, and he serves in the role as Assistant Administrator to the Diversion Control Division. Thank you, Tom and Ann, for being here today. My name is Matthew Straight. I am a Deputy Assistant Administrator in Diversion, and I oversee an office known as the Office of Diversion Control Policy. This is the office responsible for the regulatory drafting efforts of the DEA, which impact those authorized to handle controlled substances for legitimate medical and scientific purposes in the United States. I will be serving as the moderator for this listening session event. This listening session, I want to say, is novel for the DEA in that we have not generally held public meetings to inform our regulatory drafting efforts. I hope that this effort underscores our sincere desire to improve upon our information gathering capabilities to better inform this important work. At no time has this novel approach been more logical and more appropriate. And why do I say that? Because these regulations will impact the delivery of health care for every American in the United States. And frankly, we need to make sure that we get it right. We've structured this event so that we could hear from stakeholders who could either be here in person or participate virtually. We issued a notice of meeting in the Federal Register on August 1st and then gave the public until August 21st to register for the event. We received a total of 1,308 registration requests for those who wanted to participate. Of that list, 186 people requested authority to present their comments either in person or virtually. Due to the structure of the event and our decision to let each commenter provide up to 10 minutes of remarks, we curated a list of commenters with diverse views on a number of issues of interest to the DEA. 29 were offered the opportunity to participate in person, and 32 were offered the opportunity to participate as virtual presenters. Yesterday, we heard from half of our 61 presenters, both in person and virtual, and today we will hear from the remainder of our presenters. Thank you all for being here. Because we are transcribing the event, and that transcription will be part of DEA's administrative record, our presenters were advised that they could not use visual aids. While we know that some of our presenters, and indeed those who we could not accommodate, wish to provide written materials during this event, we will continue to encourage those folks to provide written materials when all interested parties are invited to respond to a forthcoming proposed rule on the subject. For the folks who registered to attend this event in person as an observer, I'm happy to report that we were able to accommodate all of you, and I'm thankful that you all chose to join us here today. Okay, let's now go over a quick run of show. This morning, our first block, our morning block, will consist of as many as 15 virtual presenters. I will call virtual commenter 1 shortly, and that individual's image will be displayed on the screen up here on the stage. Virtual commenters will be asked to state their name and their affiliation, and then they will be asked to spell their first and last name. Once we have heard from all virtual presenters, we will take a break, and this should take us to sometime around lunchtime, or around the noon hour. We will take a recess and begin our afternoon session at 12:40 p.m., where we will then hear from as many as 14 of our in-person presenters who are up in the first 2 rows. For all presenters at the 9-minute mark, commenters will hear a chime, and that will be their cue that 1 minute remains. When our countdown clock gets to 10 minutes, commenters will then hear a gentle buzz, which will be an indication to wrap up your remarks. Upon completion, we will pause in the event that Administrator Milgram or Assistant Administrator Provoznik have any clarifying questions for our presenter. Before we begin, I want to just lay out a couple of our ground rules. For our in-person and virtual presenters, I ask that you make comments that are related to the nature of DEA's rulemaking and refrain from providing remarks which are not germane. As moderator of this event, if I believe that your comments stray substantially from the scope of our rulemaking, I will interrupt your presentation and remind you to keep your comments to the practice of telemedicine relating to controlled substances. For our folks in the audience, you are welcome to get up and use the facilities at any time, but we do require our visitors to be escorted. So if you need to use the facilities at any time, please exit the door in the rear of the auditorium. There will be DEA staff there to escort you around the corner to the restrooms. If you need to leave the building, perhaps for a quick bite in our noon hour, please know that you will have to return through the visitor center that you came in through this morning. And also for our folks in the audience, much like the DEA is in listening session, so are you. There are unfortunately no opportunities for questions and answers, and we ask that everyone stay silent during the session. This will not only improve the quality of our transcription, but the quality of our simulcast for those who are watching virtually. Also, please keep your phone on silent. If you need to take a call, feel free to exit again the rear of the auditorium and take that call in our lobby. Second to last point, in the unlikely event that an audience member is disruptive, as moderator, I will ask our security team to escort you out of the building. Of course, I do not anticipate this to be the case here today. Last point, please recognize that Administrator Milgram and Assistant Administrator Provoznik may need to step away from this event for potentially significant periods of time in order to attend to their duties. Should that be the case, you may see senior personnel from either the Diversion Control Division and or the Office of the Administrator sitting here in their stead. Last, before we begin, I do want to acknowledge that as you walk in the courtyard between these 2 buildings today, you may see our flags flying at half-staff. That is to acknowledge the passing of Howard Saphir on September 11th. He was a distinguished member of the DEA family whose federal law enforcement career began in 1965 with the agency that actually preceded DEA. He served in several capacities at DEA and then later with the U.S. Marshals Service. Howard went on to serve in roles as the Commissioner of the New York Police Department and Commissioner of the New York Fire Department. His connection to DEA always remained strong during this time, and in our great tradition, we will always remain forever grateful for his service and the enduring mark that he left on the DEA and the law enforcement community at large. So with that, let me go ahead and say I will now request virtual presenter number 1 to be displayed.
Good morning. Thank you for allowing me to testify. My name is Laura Jantos, spelled Laura Jantos. I'm a healthcare technology and digital healthcare management consultant having more than 25 years of experience in the field, a 2-time traumatic brain injury survivor, and a patient advocate. I'm also the parent of 2 kids diagnosed with ADHD. I'll be speaking from a personal perspective today. My testimony is focused on methylphenidate, which I understand to be a Schedule II drug. I've been disabled due to TBI since 2012. After that incident, I was able to concentrate for 45 minutes twice a day. Making it to medical appointments and following provider directions was a significant effort, as were most activities of daily life, and left me with chronic headaches, cognitive fatigue, and a host of other symptoms because your brain basically controls everything. Essentially, the effort of getting through my healthcare was all I could accomplish. Methylphenidate, along with some medications for pain management, were prescribed to me after a second TBI in 2018 and helped me establish a platform for cognitive recovery, which has taken years to accomplish and has allowed me to be able to work again, enabling organizations to leverage technology to improve healthcare outcomes and reduce disparities. Telemedicine was a significant factor in my recovery because it eliminated the need for complex and time-consuming travel, navigation, parking costs, and other interactions that reduced my ability to improve and focus on more important tasks. Yet every month, refilling medications for myself and my children presents a significant challenge and burden with hurdles imposed by strict regulation, occasional and unpredictable payer determinations, lack of access to providers, and medication shortages. For one of my children, this is further complicated by attending college out of state and being subjected to different laws requiring providers in both locations and different processes and time frames, virtual and face-to-face, for filling prescriptions, which often results in medication gaps. The impact of TBI and other cognitive disabilities is often misunderstood and downplayed. Again, think about what your life would be if you could only focus for 45 minutes twice a day. It isn't just about being able to perform well on tests. It can be staring at a grease fire in your kitchen and trying to remember if you put that out with water or if that's exactly what you're not supposed to do. It's a difference between being able to work or not. There are also documented interdependencies between ADHD, anxiety, gastrointestinal disorders that can be so crippling that it's difficult to work, leave the house, or participate in daily activities. Consistent access to methylphenidate is critical to managing part of this triangle, and the anxiety caused by not knowing if this month's refill process is going to be simple or not can be crippling. Often the process of refill itself results in delays in access and lags that then require recovery. So the key points I'd like to make today with respect to telemedicine and e-prescribing are that, first of all, our existing certified EHR systems, which we've spent billions of dollars in implementing over the past decades, our data exchange standards, provide sufficient documentation to track prescribing provider, dosage, frequency, dispensing pharmacy, and patient information. Our business intelligence tools and artificial intelligence are available to mine this data and identify aberrant patterns without requiring undue or additional burden on patients. Having face-to-face encounters with providers is, from my perspective, unnecessary. Needs are sufficiently met by telemedicine either through video or audio, and it's important to recognize that audio-only telemedicine visits are critical from an equity perspective. Refill processes for methylphenidate are overly complicated and archaic. They include very short windows to call for that refill before you run out, then a provider verification process, again, state variability, limited quantities, and payer denials and prior authorizations. And for someone with limited cognitive abilities, this is a substantial burden that manifests and causes significant physical issues. People frequently travel between states for a variety of reasons, and I would like to see federal law enable more consistency wherever possible so that patients are not caught off guard by varying regulatory issues. I'd urge that regulations support the needs of the majority of individuals who are being aided by appropriate use of these medications and not subject everyone to compensate for the activities of a small number of bad actors. Thank you very much for your consideration.
Good morning. If I could ask one follow-up, just to clarify, you talked about the electronic health record system and the technology and digital systems around that that would be available for data mining and other sort of information gathering. As I think two questions. One is, I read you as suggesting that as an existing and potential safeguard for misprescribing and abuse or diversion. And then the second is, are you suggesting that some of that information should be shared with DEA? And if so, what information? Sorry.
Yeah, I think there's certainly potential for that information. Again, it already exists. From a patient perspective, personally from my experience, I know how much information is in those systems, yet day to day I'm asked to repeat that every time I go to a visit. We know it's stored. We have that access to that information. It certainly is possible to have access for the DEA to have access for that, to mine it.
Yep, and thank you, Ms. Jantos, for those comments. I do want to say that I think as a kind of a clarifying nature question, and to Ann's point specifically, there are a lot of perceptions that we actually have access to that information. We presently don't, and I think that's the point that Ms. Milgram was trying to make, is that it sounds like you're saying, and we certainly take the point, that that information does exist. The question is whether or not it's available to those of us who are charged with tracking diversion and misuse. Thank you very much for your comments. Before we go on to our second virtual presenter, I did want to acknowledge that we have sign interpreters that are here with us today, and those are for the folks that are here in the audience. So if there are folks that are hearing impaired and you need to move closer to see our sign interpreters, feel free to move at any time if that ends up being beneficial for you. And I thank you all for being here today. Okay, let's move on to virtual presenter number 2. You are ready to go, Dr. Bailey.
Oh, I'm sorry. Hi, good morning. My name is Dr. Felicia Bailey. I am a family nurse practitioner. I am representing Ava Essalon Healthcare in Frederick, Maryland. My presentation will be coming from the perspective of a family nurse practitioner who also provides addiction and psychiatric services. And I would like to share some of my experiences with the population that I serve, which generally are a population with severe substance use. They typically need to be housed in inpatient units and things of that nature, and developing life skills for the community. One of the recommendations, and I will have to say that there are a large population of my clients who are very good follow-through clients who usually follow the diversion or criteria for prescribing and things of that nature. They attend their appointments. They follow up with their primary care providers. One of the concerns that I have with the other half of my population is some of the common things that I've seen with potential diversion. And as a provider, it has been a challenge to make sure that these clients stay in compliance, and I also be aware of their health. Some of the things are selling prescription drugs, also doctor shopping, which some providers may have multiple controlled substances from multiple providers, and some clients may have frequent drug theft reports. In that population, I would certainly recommend that the DEA have more access to clinical documentation. And some of that clinical documentation may be screenings from other providers, a way that it does not put the burden on a family or addiction specialist to have to call a psychiatrist and verify what medications the client's on. That database could possibly include other measures to evaluate their medical health, their physical health, and just making sure that we as providers understand whether it's pain, whether it's substance use concerns, that they're also being addressed with their medical providers as well. And my recommendation would be for a collaborative relationship between the providers and primary care. Some of the examples that I would recommend is making sure that, for example, some of those medications that are commonly misused would be categories of benzos, stimulants, pain medication versus the substance use medications. If that information was readily available, it would help providers in prescribing. Also making sure, and I'm not sure if this is possible, but there has been a challenge identifying those clients who are on methadone. I have just noticed over the COVID transition that there's not a lot of clients reporting that they're on methadone. Most of them are just on Suboxone, which is good. It's a good thing that they are seeking some type of help. But the barrier that I've seen is that methadone doses are not there. I have seen some clients who, when I've requested them to come to the office, then I realize that they are on methadone or they have been prescribed Vivitrols or a medication to treat their substance, but they're not showing positive for those substances. My concern is mainly, again, making sure that data is available for all providers, making sure that we address population health. We do understand that there are certain individuals that they have resulted to abuse of substances because of their healthcare behaviors. Having a provider guide those behaviors to improve those behaviors certainly helps with the population. What we perform in the primary care environment that I work in is we actually do HIV testing, hepatitis C testing, and we refer to treatment. Referring to treatment also helps with our children, their children, just to make sure that we maintain treatment with that environment. I would certainly say that laboratory tests would actually help us, even as a substance use provider, initiate or encourage that client to continue to treatment. One of the other things that I've realized is the frequency of this population, and I see again this population, maybe those with chronic medical conditions and multi-substance use concerns. If there were emergency room data, this population circles the emergency room very frequently. A lot of times they may not reveal to their family provider that they just had an overdose 2 days ago, unfortunately. But at least having that information so that we can probe the patient and see if we can manage their care a little bit more efficiently. The other recommendation is to make sure that there is some type of point of care information inside of our databases so that we can use that information to apply treatment and counseling and recommendations for further services. So I ask for these things with all respect, just to address the population, again, that I serve, which I think is very common, but misoverlooked or underserved population. And that way we collaboratively care for our population and those with substance use disorders.
Thank you so much. Just
Thank
a
you for
couple
your
of follow-up
time.
questions. To clarify, when you were talking about the medications that you see being abused, can you just go through that list again? I missed maybe the couple at the end.
Sorry, I didn't hear you.
I'm so sorry. Can you hear me now?
Yes.
Okay, great. Just to clarify, you went through a list of some of the medications that you see being abused. I didn't catch all of them. I was wondering if you could just list those again, the ones that you see most frequently being abused.
Usually this population has a combination of pain medication, anxiety medication, stimulants. I have noticed in the COVID era that there's a lot more individuals with that combination. And it could be any category of medication that's controlled, but I've noticed there are a higher amount, and not to the fact that I don't believe that they need it. I believe that maybe a face-to-face evaluation to just really hone in on what the body is saying to the provider would be very helpful.
Thank you. The other thing, and I'm just trying to make sure I'm pulling together some of the threads that I was hearing. It sounded to me like you were talking about having some sort of national database that providers could access that would give you information on the prescriptions that somebody's on, the provider visits, the emergency room data. So the first question is that part right? Is that an accurate reflection of what I'm hearing?
Yes, that is accurate. And I would give an example. I live within 30 to 45 minutes of 3 states: Pennsylvania, West Virginia, Virginia, and Delaware. So I'm sorry, 4 states. If there is an opportunity for a client to drive within an hour, I think it would be very beneficiary for a provider to have access to that data.
Is there anything else that you would put in that data that a provider should have list?
Emergency room visits. Those are key indicators that the client is going through a crisis. And I'll make sure I clarify, because I do respect those clients who do what they're supposed to do, and they have no intentions of misuse. You will see cycles because the consistency is not there. These clients may be underinsured. These clients may be purchasing their medication from another patient, and they have more frequent emergency room visits.
With that system, would you also want the pharmacists to have access to that as well?
Absolutely. That'd be a great idea. Great idea.
Okay, I think we are done with follow-up clarifying questions and comments. So thank you, Dr. Bailey, and we will move now on to virtual presenter number 3.
Thank you.
Dr.
Hi,
Bassi.
I'm Bruce Bassi, BRUCE-BASSI. I'm with Telepsych Health. Good morning, everyone, and thank you for inviting me to speak. I want to first thank the DEA for holding these listening sessions. Thank you for trying to find the right solution that is least burdensome, but also maximizes patient safety. We heard a lot of great ideas yesterday, and what struck me was the incredible diversity of practices and disease types that we all use controlled substances to help treat. Treating substance use versus chronic pain versus hospice versus ADHD are all very different. And this emphasizes the great challenge the DEA has in trying to apply a simple blanket policy across all disciplines in the entire country. All speakers were correct in their own right, because the decision to prescribe or not prescribe should be one that's made between the clinician and patient. So the question becomes how to prevent bad actors from taking advantage of a very lenient system to prevent what happened during the COVID health emergency, when we essentially had a trial period for how this would go. I think some of my recommendations would address that. Let me introduce myself. I am board certified in general psychiatry and addiction psychiatry. I'm the sole owner of the private practice Telepsych Health, which is mostly virtual and accepts commercial insurance and Medicare. We have an office for in-person appointments in Jacksonville, Florida as well. Despite being a virtual practice, we do not expect to profit at all by more lenient regulations in this regard. because we prescribe a very low percentage of controlled substances overall. I have a DEA license in states where we have partnerships with certain facilities, the most notable of which is with our partnership with a prison reentry program, where we primarily evaluate substance use disorders and prescribe buprenorphine to some of those individuals. In the year 2022, we had a total of 32 patients prescribed buprenorphine. The vast majority of our patients do see us for general psychiatric reasons, and I run a virtual group therapy as well. During COVID, we wrote for controlled substances for people with severe anxiety, insomnia, and ADHD, and this comprised an additional 34 patients in 2022. In total, we sent in 15,000 different prescriptions that year, and 406 of which were for controlled substances, for an overall rate of 2.6% of prescriptions sent. Before I prescribe any controlled substance, there are a number of factors that I would consider clinically before deciding if this is an appropriate choice. First, have they completed a written consent form that outlines our clinic policies of expectations? For example, they may be asked to obtain or collect a urine drug screen randomly to be done at their local lab within 2 days or at a facility that they're affiliated with. Also, that the medications need to be locked and out of reach of any other person to prevent diversion and accidental diversion from any children or teenagers in the home. Simultaneously, during the appointment, I'm considering a number of other important factors, such as 1, the patient's age and history of substance abuse. If the person has a history of drug abuse, I'm thinking about other co-occurring conditions, where they are in the recovery. Do they have a sponsor? How much support do they have? Are they going to groups, etc.? Secondly, I'm considering family history of substance abuse. We know there's heritability of addictive disorders, not only through genetics and epigenetics, but through its impact on childhood trauma. Third, I'm considering the duration of the prescriptions. Is it a bridge to starting another medication, or is there no discernible endpoint to the prescription? Fourth, I'm considering escalating doses and early refills, which I would find by checking the PDMP, which I think is extremely important, and I do before prescribing any controlled substance. Fifth, what is the addictive potential of the medication I'm prescribing? We know that not all schedules are the same, and I consider what is the time release rate of the formulation that I'm prescribing. In 2022, of the 66 patients who were initiated on controlled substances remotely with no in-person visit, 93% of them were continued without an issue. Of the 7%, we treat each breach of contract on a case-by-case basis to try to figure out what was the underlying intent of the relapse, or if they intended to manipulate and deceive us. If needed, I can expand more on how we might approach those cases. In an informal Facebook poll of physicians in preparation for this talk, 64% stated that clinicians should be able to use their best judgment in prescribing controlled substances virtually and without any regulations. 32% stated patients should be required to see somebody in person first, and only 2% agreed that there should be a telehealth registry. Therefore, the vast majority felt prescribing controlled substances should be a decision made between the physician and patient. In my opinion, I don't see a one-time in-person examination reducing the risk of abuse, nor do I see it materially altering the potential for diversion, nor would it add to me substantial information to a psychiatric appointment that I could not gather virtually. None of the 5 other clinical concerns I stated earlier would be changed if some arbitrary person saw them once previously. Furthermore, it's important to point out online notaries have existed for a number of years now, thus verifying an individual's identity virtually has been legally acceptable. An in-person requirement will also unfairly burden rural patients, those without transportation, and those without childcare. Like I mentioned earlier, the new rule should take into consideration that there are practices that have a high volume of controlled substances and pose an overall greater risk to the public versus those who do not. I noticed during the COVID emergency, there were a number of companies that popped up with their entire business model predicated on solely prescribing controlled substances. Given the addictive potential of controlled substances, this presents an unethical conflict of interest wherein profit is inextricably linked to prescribing, and thus prescribers are partially incentivized to starting and continuing these medications. Therefore, I think the upcoming DEA policy should attempt to reduce the potential corporate entities can profit off lenient prescribing rules, but without putting an excessive burden on those who are thoughtful in their prescribing. One way to do this is by having increased oversight on telehealth prescribers who choose to prescribe a large number of controlled substances per month. there should be transparency about what those cutoffs would be and what additional oversight would be. I would suggest a cutoff of more than 200 controlled substances per month, which can be tracked through the PDMP. And I do support a national PDMP as well that was suggested earlier. For all schedules 2 to 5, I would recommend the following apply to all clinicians regardless of reaching the cutoff. 1, prohibit direct-to-consumer and social media advertising for prescribing of controlled substances, in particular for buprenorphine or ADHD solely. 2, require that the clinic obtain a copy of the patient's government-issued ID and that the telehealth visit must include a real-time interactive video evaluation, not just a review of questionnaires and symptom checklists that were completed by the patient. 3, require that patients complete a written consent form outlining risks, benefits, and alternative treatment options, safekeeping of the medication, and clinic policies and circumstances in which the prescriptions would be discontinued. 4th, allow clinician reporting to the PDMP when a prescription was discontinued by the clinician due to an aberrant behavior or breach of clinic policy. This would allow other clinicians to see that the patient previously breached a contract with that practice and take appropriate next steps to perhaps reach out to that practice to get more information. If the prescription was labeled to be made via telehealth, I fear this would add unnecessary scrutiny and fear by the pharmacists and add more barriers to the patients receiving the medication. Also, for clinician safety, the prescription should not publicize their home address if they're working from home. The prescriber should only need a DEA license in one state where they're physically present and not have an office in every DEA license in every state. 6th, allow for one-time refills by covering staff in the same practice. Regarding the increased oversight beyond the cutoff, I would suggest 1, the practitioner be registered for a high-volume DEA registry to cover administrative costs for additional supervision by the DEA. 2, the practitioner should be required to complete additional continued education for recognizing and treating addiction and diversion. And 3, be subject to increased audits of record keeping to ensure they're following the standard of care in their prescribing practices. In regard to the record keeping, I would recommend all practitioners to document 1, that they've verified the patient's identity with a government-issued ID and it corresponded to that video image. 2, that they have obtained the written consent form talked about earlier from the patient outlining clinic policies and diversion mitigation steps. 3, that they've checked the state PDMT prior to issuing the prescription. And 4th, in addition to documenting the standard medical history and current medications, the practitioner should have evaluated for static and dynamic patient risk factors for substance misuse and abuse, including family history of addiction, any aberrant behaviors such as a rapidly escalating dose, lost prescriptions, early refills, and any actions taken by that clinician to address these issues. Thank you for your time. It was an honor to be invited today, and I welcome any opportunity to be part of the ongoing conversation and collaboration. Thank you.
Thank you so much. Could I ask you to expand a little bit on you mentioned you could talk a little bit more about the 7% that relapsed or had fraud. Could you just tell us a little bit about,
absolutely.
How did you identify that? What did you do?
Like somebody mentioned yesterday, I tried to not take a punitive approach. Stopping the prescription and sending them to another practice makes that disease state become another clinician's issue, and they have no background information off which to work with. I would try to use the situation as a way to rehabilitate the individual, promote honesty, and reducing shame of withholding information in the future. Some people make impulsive mistakes, and they need to learn from those. It doesn't help them in the long term either to deceive us for certain scripts. So at first I would get confirmation testing of the UDS before jumping to any conclusions. I would also start to reduce the quantity of prescriptions that the pharmacy would be dispensing, increase the frequency of appointments, and maybe perhaps implement more peer support. There's a lot of virtual online peer support as well that we could require of that patient. Request that they obtain a sponsor and follow up with what they're working through with that sponsor. And then also require that we perhaps obtain additional collateral information from family members to help keep them accountable for what they say they're doing in the clinic.
And how did you identify that 7%?
It was primarily through other clinicians who had reached out to us to let them know, like therapists, and also positive urine drug screens that led to a conversation about their relapse.
sorry, sorry, I'm going to give it to Tom in 1 second. You talked about an audit checking the state PDMP. One of the questions, just to sort of ask you to expand on that a little bit, is if we're talking about a national, you recommended a national registry for telehealth, or not having multiple registries. How would you go about identifying or understanding whether or not there was a prescription in another state?
So the PDMPs have expanded quite substantially over the last year, 2 years even, where you can add additional states. And that has been extremely helpful. We know patients travel quite frequently and they might live on a border, like another presenter alluded to. So many of them, I'm registered with the PDMP in all of the states that I have DA licenses in, and most of them now you can add up to 30, 40 different states. I do think that while that's progress in the right direction, it still leaves for the possibility that you don't check off those additionally. It should just be by default that you're seeing that across the country. And also I would add, the previous presenter mentioned a couple of other additional points that could be included in that PDMP, which is a great database we already have that we can just approve upon, is identifying, okay, I'm seeing this patient who has recently gotten prescription over the last 3 months from 3 different doctors. What does that mean? Let's try to reach out to them. Like somebody mentioned, you often call an office and you get a call center. Well, one way we can resolve that is by marking down that this was discontinued due to a breach of contract. That way I know, okay, this wasn't due to doctor shopping, but they actually had to travel for some reason, or they got stuck where they ran out of medication early, or they have an issue medically where they need a higher dosage, and that wasn't an aberrant behavior. And so I shouldn't look additionally into this versus something that was done with malicious intent, where they were trying to actually deceive and withhold information from their previous prescribers.
Could you help clarify, I think you said, and please correct me if I'm wrong, that you did not want the prescriptions to indicate that it was telemedicine. However, is that correct?
I think I'm torn on that after hearing from the previous pharmacist yesterday. I really understand they are burdened with trying to identify if this is a legitimate relationship between doctor or patient, when on the spot, they don't have enough information to make that determination. And right now, there's so much stigma attached to whether or not it was a telemedicine visit that those patients are placed under increased scrutiny in particular states and particular pharmacies due to the excessive overabundance of prescribing habits that we seen during the COVID emergency. So, it could include that it was telehealth if there was less fear among the pharmacists that it's not up to them to establish whether or not it was a correct relationship, because they're not in the doctor-patient appointments, and it's not possible for them to police that. It should be the prescriber's responsibility, and there shouldn't be additional barriers where the patient needs to hop around to 10 different pharmacies and identify which pharmacy is known for allowing them to give them their prescription, which has happened in certain cities that we've experienced.
Okay, thank you. But to further, another point that you made was for us, for I guess DEA to identify the telehealth companies, to take a stance against the corporations. How would we do that if we don't know what the prescription, where it's generated from, if it's a telemedicine? So how would we, do you have suggestions on how we would do that?
Right. The PDMP can include that it was made via a telehealth visit, and then that way they can monitor if that prescriber is approaching or exceeding the cutoff that was already demarcated by the DEA, and then they can apply for additional registry. I think the burden should be on those individuals. The increased regulation burden should be on those individuals who are high volume controlled substance prescribers, where they undergo those 3 additional recommendations that I made, having a registry solely for those individuals, kind of like for buprenorphine previously, with varying levels for each prescriber. depending on their level of experience. I think that makes a lot of sense to me, and that's the only way that I can think of that would start to separate those bad actors who are essentially becoming the pill mills. I hate to use that colloquially, but that's essentially what they become known as.
Okay. Thank you, Dr. Bassi. I will now move on to virtual presenter number 4.
Good morning. My name is Dr. Alex Armitage. I'm a supportive palliative care nurse practitioner at Baylor Scott & White Health in Texas. My name is spelled Alexandra, last name Armitage, Armitage. The System Director of Supportive Palliative Care at Baylor Scott & White has asked that I testify on behalf of our entire service line. Palliative care at Baylor Scott & White consists of 13 interdisciplinary teams covering 18 facilities scattered across about a third of Texas. Most of our patients come from the 11 million people living in this service area, but we also draw patients from New Mexico, Oklahoma, Arkansas, and Louisiana. Our 13 supportive palliative care teams include 64 board-certified hospice and palliative care physicians and advanced practice providers. In fiscal year 2023, we provided over 63,000 total patient encounters, with over 6,000 outpatient encounters. Early palliative services allow patients to be embraced holistically and cared for in the most humane possible way at a time when they are most vulnerable and most in need of care. Early delivery of palliative care reduces unnecessary hospital admissions and the use of unhelpful health services. In other words, palliative care patients are less likely to receive non-beneficial treatments. To demonstrate some of the challenges that our patients face, let me share a clinical vignette. Sally is a 36-year-old runner and mother of 2 children who I served since shortly after she was diagnosed with stage 4 breast cancer 3 years ago. Chemo and radiation therapy was initiated by her oncologist, who also referred her to my clinic for help managing her physical and total pain. As with most patients newly diagnosed with metastatic cancer, she was not a hospice candidate as her cancer was being actively treated and she had a projected life expectancy of over 6 months. Her pain was so great that traveling the 2 hours to my office was not imaginable to her. Due to COVID, I had already been tasked with establishing telehealth video services for palliative care at Baylor Scott & White, and so I was able to set up such a visit with her. On our first video visit, Sally's pain was so intense that she could not sit up in bed due to metastatic lesions through her spine and pelvis. She was literally reduced to tears because of her pain. I was able to complete a comprehensive evaluation, and we explored her goals of care. Sally and I agreed on what an acceptable level of pain would be, and she was started on a combination of methadone and morphine. Over the following months, we titrated her pain medications not to complete absence of pain, but to a level of pain control that would allow her to resume at least some of her activities of daily living and possibly get out of the house for a short period of time. I'm proud to say that we've been successful. On her most recent video visit last week, she was out of bed and dressed. She had improved enough to take a short trip to the hairdresser, which made her proud as her hair was growing back after chemotherapy. She was even able to get up and cook a simple meal for her family. Yet she still struggles with traveling long distances in the car. I'm not in her shoes, but I cannot imagine her being comfortably able to travel to my clinic, nor do I think it necessary. We know, and more importantly, she understands that she will never be 100% pain-free and that eventually her cancer will return. But she, her oncologist, and I are thrilled at the moment that she no longer lives immobile in a bed of pain. In case it's not clear from my story, I have yet to meet Sally in person, but the treatments that I've been able to provide to her via video have given her her life back. And I thank the DEA for the suspension of the in-person rule during COVID, which allowed us to relieve her suffering. As many know, palliative care and hospice services are frequently confused. And when that happens, referrals come late, which diminish benefits to patients, their families, and healthcare providers alike. To help alleviate that problem, Texas law recognizes, and my health system recognizes, two types of palliation. The first, and more familiar to the public, is hospice, for which enrollment requires the patients to forego attempts to treat their primary disease. There are over 570 hospice agencies in Texas, serving less than 1% of us who will die in any given year. Hospice typically provides services for days to weeks before death. My patient Sally was not hospice appropriate as she was actively undergoing cancer treatment and had a prognosis of greater than 6 months. The second type of palliative care is what Texas law and Baylor Scott and White refers to as supportive palliative care. Our patient population is seriously ill, the sickest of the sick. Like Sally, they often have extremely high symptom burden, including some of the worst pain imaginable. Although we would not be surprised if any of our supportive palliative patients were to die in the coming year, annual mortality rates are in about the 50% range, clearly not hospice appropriate. And like Sally, our patients wish to maintain disease-directed treatment. Thus, unlike the typically short service time for hospice patients, in supportive palliative care, we serve patients for months to years, most commonly in the hospital or clinic setting. Unfortunately, in Texas, supportive palliative services are not as available as hospice. For example, the most recent data available suggests that only 154 of the 262 hospitals in Texas offer supportive palliative care services, and most of those are hospital-based only. Even in our system at Baylor Scott and White, with 13 supportive palliative care teams, we are only able to staff 6 outpatient clinics. In addition, unlike hospice, we do not receive a per diem fee and do not have the staffing available to send professionals to the patient's home. This means that if we are unable to provide telehealth services, our patients must come to us. Hopefully, all can understand how challenging such travel is given the symptom burden and the distances involved, distances which can grow to hundreds of miles in some cases. I have set up 2 telehealth clinics in the last few years, servicing hundreds of sick patients. I could tell you many more clinical vignettes like that of Sally, but we don't have the time. In closing, my supportive palliative colleagues and I recognize the need to protect the broad population from opioid abuse. But we believe that such protection must not impair effective pain treatment and other symptom management for the seriously ill, the sickest of the sick patients with life-limiting illness. Our patients cannot always travel to see a medical provider in person because of the distances involved and because of the severity of their symptoms. For some patients, obliging them to do so would effectively be denying them care. We advise against placing any regulatory hindrance in front of the barriers already created by their life-limiting illness and all the geographic distances required to reach our limited clinics. We believe that the Drug Enforcement Administration was correct in suspending the requirement for the in-person visitation for opioid therapy during COVID, and we recommend that, at least for patients of supportive palliative care professionals, that this humane suspension be maintained. We recommend that the DEA carve out Schedule II prescribing rules for prescribers in supportive palliative care and allow such prescriptions via telemedicine visits alone, thus negating the severity of illness and travel distance barriers that I have shared with you today. Thank you for the opportunity that you've provided us to testify. My colleagues and I would be happy to participate in any further dialogue.
Okay. Thank you, Dr. Armitage. I think we have no questions, so we will now move on to our virtual presenter number 5.
Morning. Is my audio okay?
Yes, it is.
Thank you. My name is Roxanne Tyrock. I live in El Paso, Texas, and I am an internist in telemedicine, PA. As a primary care physician in an office setting, I prescribe controlled substances on a regular basis. The most common ones are for adult attention deficit disorder, which are Schedule II amphetamines. During the pandemic, it was reasonable to drop regular safeguards when there were no COVID vaccines nor treatments. Now that the pandemic no longer poses these risks, there is little valid justification to extend this laxity in safeguards against diversion and health-related hazards. Our clinic has urine drug screening for the use of controlled substances. The patients must first have their first visit in the office always and have annual in-office physical examinations and wellness visits. And monthly, they have the option to do their drug screen in the office and then at the same time as an in-office encounter, or they can do a telemedicine visit and then do the urine at their convenience. If there are any concerns during the telemedicine visit, as far as safety, say they have chest pain or some symptom of concern, then the patient comes to the office and an EKG, physical exam, or whatever is needed to do to remedy the situation ensues. In October 2022, the FDA announced a shortage of amphetamine mixed salts, pointing to ongoing intermittent manufacturing delays at Teva Pharmaceuticals, a major supplier of Adderall amphetamines. Due to the Adderall shortage, my patients now have to call around to pharmacies in order to get verbal confirmation that there's adequate supply, and then we hold our visit right away so that they can get to the pharmacy within hours of it being written. And even this fails, and they'll have to find supply elsewhere. By returning to proper safeguards of only prescribing to patients that have had an in-office evaluation, we are ensuring that the medication is directed to people who are appropriate to receive the medication. There are many other benefits to this procedure. The physician ensures cardiovascular safety with the use of amphetamines with an electrocardiogram and physical exam. Any concerns found on drug screening can be addressed in a personal setting. The American College of Cardiology published guidelines on the topic in April 2015. And this was an expert analysis with 28 references outlining the challenges of prescribing these medications, even in a proper setting, such as an office. The package inserts for stimulant drugs warn against use in patients with pre-existing heart disease or cardiac structural abnormalities due to risk of sudden death, stroke, or myocardial infarction. Furthermore, the FDA issued a safety announcement in 2011 stating that stimulant products and Strattera should not be used in patients with serious heart problems or for whom an increase in blood pressure or heart rate would be problematic. There have been reports of Strattera-induced life-threatening lung QT syndrome. It's recommended that methylphenidate and amphetamine-containing drugs be avoided in patients with congenital lung QT syndrome. Package inserts for modafinil and armodafinil warn against use with patients with a history of left ventricular hypertrophy or those with mitral valve prolapse. The final summary of this document emphasized how proper assessment of clinical benefits and risks should be made on an individualized basis when therapy is warranted. Monitoring of cardiovascular parameters is in order and should be limited to the lowest effective safe dose. As an additional side note, my daughter is a college student, and I asked her, what have you noticed about people's use of amphetamines in school? And she noticed that after the pandemic, when this change took place, that just anecdotally, it was noted to more diversion of stimulants in the college student setting has been identified. And I understand the potential motive of prescribers that seek to lower standards for telemedicine-only prescribing of controlled substances. If no brick and mortar building is required, the overhead plummets and profit will rise. And I would submit to you that this is not a good enough reason to allow for telemedicine-only prescribing of controlled substances in the setting of drug shortages. All patients deserve the safeguards and personal care that I've outlined. It's simply incomplete to not have those options available when needed. Handheld cardiac devices and do-it-yourself heart monitoring, in my experience, has not been adequate to screen for arrhythmias. And I wish to thank the DEA for having this listening session and demonstrating that you want to have as much information at hand with these important decisions. Thank you very much.
Good. Okay, thank you, Dr. Tyrock. I don't see any questions, so we will proceed on to virtual presenter number 6.
Great, thank you so much. My name is Dr. Connie Gill. First name is C-O-N-N-I-E. Last name is G-U-I-L-L-E. I'm from the Medical University of South Carolina. Again, just wanted to say thank you very much for having us here today and the opportunity to speak with you all. As I mentioned, I'm from the Medical University of South Carolina, where we're one of 2 federally recognized and funded National Telehealth Centers of Excellence by the Health Resources and Service Administration. Our center has over 300 telehealth programs throughout our state, on average about 800 telehealth visits per day, primarily to rural and underserved areas within our non-Medicaid rural state. Since 2015, I specifically have been working in the space of treating pregnant and postpartum women with opioid use disorder using telehealth modalities, and particularly prescribing Suboxone via telehealth. My comments today are actually very specific to the pregnant and postpartum populations and recommendation to not require an in-person visit prior to prescribing Suboxone for the treatment of pregnant women with opioid use disorder and postpartum women. Just to highlight a few things that I think are relevant, in the United States, our rates of maternal mortality, which is death during pregnancy in the postpartum year, is higher than any other developed country. And the leading cause of maternal mortality in the United States is due to mental health conditions, primarily due to suicide and drug overdose. And that overdose deaths are primarily related to opioids, and they occur typically later in that postpartum year. I think it's just important to note that since 2010 to 2019, we've had about a 190% increase in pregnancy-associated deaths just due to drug overdose. The most recent data shows an 81% increase in those pregnancy-associated deaths due to drug overdose from 2017 to 2020. The vast majority of these deaths that we know from our state maternal morbidity and mortality review committees are actually preventable, and they're preventable by providing better access to care. And particularly for opioid use disorder, life-saving medications such as Suboxone. There have been a number of studies, those including JAMA Psychiatry, of over 200,000 Medicaid recipients that have shown that telehealth expands access to treatment for opioid use disorder. It results in improved retention and treatment and reduced rates of overdose deaths. And furthermore, utilization of this during the pandemic was associated with improved retention and treatment of opioid use disorder and decreased overdose deaths in comparison to our pre-pandemic cohorts when we required an in-person visit. Our concern today is that any progress that's been made towards improving access to evidence-based treatment for opioid use disorder and reducing opioid overdose deaths will be reversed by requiring the proposed in-person visits before we can prescribe Suboxone for the treatment of opioid use disorder. I just want to add that where we are in South Carolina, we've had the firsthand experience of the detrimental impact of resuming the in-person visit requirements. In April of 2022, South Carolina announced a return to pre-pandemic state regulations for prescribing controlled substances via telehealth. As a result, that has resulted in increased in no-show rates to that in-person visit and unsuccessful treatment engagement, despite actually an investment in outreach and additional personnel to try to engage people in that in-person visit. We were given 180 days to transition all of our patients from the pandemic requirements to coming in for an in-person visit. We were really unsuccessful in doing that, and a number of patients dropped out of care and were no longer retained in treatment, which is retention in treatment is what predicts reduction in overdose deaths. So I want to highlight that in our clinical practice, when we see pregnant and postpartum women with opioid use disorder, we can accomplish everything that we need to safely manage that disease without having an in-person visit. Using telemedicine, I can make an appropriate diagnosis of what is happening with that person. I can look for signs and symptoms of intoxication and withdrawal. I can check my state prescription drug monitoring program. I would like to be able to check other states' prescription drugs monitoring programs in order to determine if there's any other prescribers on board or multiple medications being prescribed to this patient. In that, I'm able to safely prescribe these medications. The only thing that the in-person visit does is it actually creates additional barriers to these patients accessing treatment and prevents a lot of people from accessing these treatment. We've had the firsthand experience of requiring that in-person visit, resulting in delayed care and an overdose death of a pregnant woman. And it's continued to have that happen is not acceptable. I agree with a lot of the presenters before in terms of the safeguards that can be put in place with reducing drug diversion, but just want to be very clear that that in-person visit does not increase our chances of reducing drug diversion. With that, I will stop and just say again, thank you very much for your time today and our ability to present this information to you.
I have a question. You keep saying inpatient, not having an inpatient visit. Is your practice two-way or is it audio only? I'd like to hear your perspective of audio only as an initial visit or two-way. Get your perspective on that.
Yeah, so I'm sorry for not being clear on that. When I say telemedicine and a visit with a patient, it's using audio and visual telehealth. The only thing I'm suggesting is that they don't come in person to meet with us before we prescribe medication, that we can achieve all of that using audiovisual telehealth synchronous encounters. And
excuse me, you talked really fast in the beginning. When you were talking about the medical university, you indicated that it got some sort of certification. Could you explain what the certification is, and what was the process for you to get that certification?
Sure. So HRSA, Health Resources and Services Administration, is a organization that has federally recognized and funded the MUSC, or Medical University of South Carolina, as a National Telehealth Centers of Excellence. And so what we are tasked with within the Center of Excellence is advancing telehealth and demonstrating the effectiveness of telehealth programs in terms of providing greater accessible and effective care via telehealth in our state.
Do you know what the process was for you to get that Gold Star of Excellence?
Yes, so that HRSA puts out a call for proposals. There were many proposals throughout the United States, and they only designated South Carolina and Mississippi for that recognition as a center of excellence.
Okay, thank you.
Sure.
Okay. Thank you, Dr. Gill, for your time today, and we will now move on to virtual presenter number 7.
Thank you. My name is Caitlin, Caitlin Gillooley, Gillooley. I'm the Director of Behavioral Health and Quality Policy at the American Hospital Association. And on behalf of our nearly 5,000 member hospitals, health systems, and other healthcare organizations, as well as our clinician partners, the AHA appreciates the opportunity to provide input on the way forward for telemedicine prescribing of controlled substances. Now, we recognize and appreciate the DEA's efforts to support safe prescribing of controlled substances via telehealth during the COVID-19 public health emergency. Indeed, during the COVID-19 PHE, the DEA enacted certain flexibilities to ensure that patients could continue to receive life-saving medications via telehealth while minimizing exposure and preserving provider capacity. However, we are deeply concerned about the DEA's refusal to implement a special registration process for telemedicine prescribing of controlled substances, and we disagree with the direction of the two proposed rules issued this past March. The rules would impose burdensome restrictions and administrative requirements that we believe are overly burdensome on providers and patients, which we are concerned will adversely impact access to medically necessary treatments. So we have several recommendations in response to the proposed rules. We express these in our written comments on the rules. We reiterate them today. Our primary recommendation to the DEA is to develop and implement a special registration process in lieu of the proposed regulatory guardrails contained in the aforementioned rules. Now, first, we urge the DEA to expeditiously set forth a special registration process and establish a pathway to waive in-person evaluations prior to the prescribing of controlled substances for practitioners who register with the DEA. Indeed, the Ryan-Haidt Act required the DEA establish this process nearly 14 years ago, and the Support for Patients and Communities Act reinforced this requirement and applied a clear timeline for the process's development by 2019. In the March 2023 proposed rules, the DEA noted that it had determined a special registration process would be overly burdensome for providers. However, as I will elaborate upon later in this testimony, the provisions proposed by the DEA would certainly add significant burden for providers. Further, we believe that a special registration process would simply be complementary to the existing DEA registration process rather than a new and distinct process that prescribers would have to go through on top of their current licensure. For example, practitioners, hospitals, clinics, pharmacies, and others are currently required to complete applications for registration and renewal of registrations for prescribing controlled substances, namely Forms 224 and 224A. The process has already established guardrails that build upon state medical licensure processes and Medicare reporting. So rather than creating a novel and separate process or form, DEA can add fields to those forms that providers already use. This way, the special registration process would include key elements that providers already report, like their contact information, their employer, practice address, state medical licenses, liability history, etc., and could add unique attestations on patient identification verification via telemedicine, drug monitoring, diversion control, and emergency protocols. We would encourage the DEA to not require reporting of home addresses if practitioners are administering telehealth from their home address due to privacy concerns. We would welcome the opportunity to assist further in developing a proposed special registration process and establishing appropriate guardrails. Next, we appreciate that the DEA has recognized the need for additional time to consider creating the special registration process and has extended the COVID-19 pandemic era rules through this coming November for new patients and November 2024 for existing patients. However, considering the enormous volume of comments received on the rules this spring, as well as the wealth of information that is being shared during these listening sessions and the additional comment period announced yesterday, we believe that the agency will have to further extend public health emergency waivers to ensure that people who need access to appropriately prescribed controlled substances can get them. And that should be the case regardless of whether they're a new or established patient. So the DEA has already exercised its authority to extend PHE waivers of the in-person visit requirement. We believe they should exercise this same authority to create an additional provision that would allow for extensions of the waiver for prescribing buprenorphine for all patients, including those who did not begin their OUD treatment during the PHE. Buprenorphine is a unique substance used for a specific life-saving purpose, and the agency has the authority to extend PHE-era waivers to ensure continued access to this treatment while we work to develop a permanent framework. Alternatively, the DEA can use authority granted under the public health emergency for the opioid crisis, which was renewed most recently on April 1st of this year, to extend these waivers. Just as DEA used its authority to allow for the initial evaluation to be conducted via telemedicine during the PHE for COVID-19, the agency has the discretion to use the same authority under the opioid-specific PHE to allow the practice of telemedicine when it is being conducted during a public health emergency declared by the Secretary under Section 247D of Title 42. So we urge the DEA to act under this PHE as intended to innovate and implement a variety of actions to combat the opioid epidemic, such as a special registration process for the telemedicine prescribing of controlled substances, including but not limited to buprenorphine for the treatment of OUD. So this process would be an efficient and effective way to allow practitioners in good standing to appropriately prescribe controlled substances for legitimate clinical purposes. Conversely, the provisions proposed by the DEA in this March's rules would be overly burdensome to providers and would erect unnecessary barriers between patients and evidence-based therapeutics. So in those rules, the DEA proposed that prescriptions administered via telemedicine would not be able to exceed a 30-day supply without an in-person visit. We are concerned that these limits are arbitrary, unnecessarily burdensome, and will reduce access to critical care. There is no scientific evidence suggesting that 30 days is the appropriate interval for patients undergoing treatment with controlled substances to be evaluated by their physicians. The 30-day limit would require patients to complete an in-person evaluation before obtaining more medication. For many patients, it may be impossible to get an appointment with a practitioner in just 30 days. Such as patients who live in geographically remote areas, who have childcare limitations, or who have conditions that make traveling to appointments physically painful. While some patients may benefit from a periodic in-person evaluation, the need for an in-person evaluation should be left to clinical judgment rather than enforced through a general requirement that ignores individual needs. Telemedicine encounters are designed to use the extremely limited availability of healthcare professionals the most efficient way possible, and thus requiring superfluous interactions with little benefit negates those gains. So we recommend removing any supply limit and instead allowing clinicians to determine the frequency of in-person exams. The proposed rules issued in March would also impose significant administrative burden through record-keeping requirements on prescribing practitioners, the referring providers, or other providers physically present with the patient during a telemedicine visit, and their staff. We urge the DEA to reconsider what type of information is truly necessary and whether it can be gleaned more easily from other sources like claims and medical records before imposing record-keeping tasks on the already overburdened workforce. In the rules, the DEA states that the additional record-keeping requirements are necessary to mitigate the risk of diversion. However, the agency did not provide data demonstrating that the proposed requirements are associated with decreased diversion. In fact, during the COVID-19 PHE, when practitioners were allowed via waiver to prescribe controlled substances, specifically buprenorphine for the treatment of OUD via telemedicine, the proportion of opioid overdose deaths involving the substance did not increase, suggesting that the risk of diversion did not increase, absent additional guardrails. So practitioners who prescribe controlled substances already keep detailed medical records. These additional record-keeping requirements would not provide further protections. Now, although many of our comments specifically refer to the prescription of buprenorphine for the treatment of OUD, we should not lose sight of the longer list of use cases for other controlled substances. Because the rules focus separately on buprenorphine and all other controlled substances, we are concerned that DEA is unaware of the myriad appropriate clinical use cases for these medications. The proposed rules issued in March would limit telehealth prescribing of controlled substances without a prior in-person visit to Schedule 3 through 5 non-narcotic medications and buprenorphine only. The rule states that prescribing any Schedule II or narcotic substances via telemedicine would pose too great a risk to public health and safety. The agency relies on a general assumption that because controlled substances can be misused, an increase in access would result in increased risk for diversion. The assumption not only overstates the risk of diversion, as I previously mentioned, but it also fails to consider the millions of Americans who may be adversely impacted from an inability to access medically necessary medication through virtual prescribing. Few examples of the circumstances, and I'm sure you've heard these today already, where prescribing of Schedule II controlled substances and narcotics may be clinically appropriate, may include a homebound palliative care patient receiving opioids for pain management, a person with cancer with transportation limitations, a person with epilepsy living in remote areas receiving anti-seizure medication, a child receiving ADHD medication virtually due to a lack of pediatric psychiatrists in the immediate service area. So we recommend that DEA add circumstances under which Schedule II and narcotic medications can be eligible for telemedicine prescribing without an in-person exam. Circumstances which would waiving the in-person requirement could include certain diagnoses or disease burdens like hospice and palliative care, and or the inability to travel to in-person appointments. And again, we are happy to assist with the development of these provisions, and we thank the DEA again for the opportunity to provide comment and would welcome further dialogue on our recommendations. That's all I've got.
Okay, thank you, Ms. Galuli, for those comments. I do see that Tom does not have any follow-up questions. So I will go ahead and go to virtual presenter number 8.
That me? I'm not sure.
Yes, Mark.
Yeah. Okay, I'm having a hard time finding. It was just there a minute ago. join us in Zoom now. Okay, I don't have my tele video working. I am having problems with that now, but, oh, there we go. Can you hear me and see me?
Yes, sir.
Okay, good, fine. I am Dr. Mark Berger. I am an old-fashioned, real general practitioner, family medicine doctor, and I have a few comments from my personal experience and also from some of my beliefs. One of the first ones is when I was practicing, I used to do controlled drug substance, both in my practice individually and also as a takeover physician from a narcotic clinic. At the time, we were doing real visits once a month with them, and I thought that was very good. There are some interesting things I noted. One, telehealth. I feel very strongly opposed to it for control to narcotics, but I am perfectly in support of telehealth, telemedicine for control to non-narcotics, particularly the ADHD drugs. I do prescribe them on occasion. It has been a difficult burden. This is a chronic condition that is unlikely to change. ADHD, attention deficit hyperactivity disorder, on Ritalin, Adderall, et cetera. And I feel that that would be very reasonable to do through telemedicine. However, controlled drugs, particularly controlled 3s and controlled 2s, I'm talking about hydrocodone, which used to be a controlled 3, I find very difficult to perform telemedicine, and I'll give you some examples. I do telemedicine for medical marijuana in the state of Florida. This has been off and on. It has been exceedingly difficult to perform telemedicine because there is no physical examination possible. And many of the conditions require a reassessment of the severity and the appropriateness of the continued use of the drug. For things such as chronic pain, there is no alternative to a physical examination to determine if the pain is still severe enough to continue with medical marijuana. For some of the other conditions, that might not be unreasonable, but for some things, you do need a physical exam. I have in the past suggested that telemedicine for the purpose of any visit which traditionally requires point-of-care testing or physical exam is substandard of care. I do not see how you can diagnose sinusitis through telehealth. I do not see how you can assess back spasm, chronic pain, back pain, acute postoperative pain, or any other issue by telemedicine. I believe that since ADHD is primarily a psychological condition and there are screening tools and it is a talk, that it is reasonable to prescribe telemedicine for non-narcotics. Some of the missed opportunities I have noticed, there is an inability to do a random drug screen or a true drug screen when you do not have an in-person visit. My practice was to do an in-person drug screen. We did occasionally find people who had made mistakes, had cheated, had used marijuana, had other drugs. Some of them were counseled, some of them were discontinued. Sometimes I required extra testing. I have had people who have had random testing that was false positive, and when they came to visit me, I did a supervised high-quality liquid chromatography test and proved that was not the case. So the point-of-care lab, especially urine drug screens, cannot be done through telemedicine adequately, in my opinion. Physical exam cannot be done. I routinely do examine my patients. I have found at least 3 people who I think I've saved their lives from medical marijuana, non-telehealth recertification, established patients, finding suspicious-looking moles, a new atrial fibrillation arrhythmia, and one other diagnosis. I've also made suggestions for alternative treatments that I have seen. I can't evaluate a postoperative scar. I can't evaluate a CT scan, an MRI report, a real film at telemedicine, and sometimes that does change my prescribing, particularly for medical marijuana, but even for controlled drugs. I have had patients on controlled drugs for temporary period postoperatively when the surgeon did not do an adequate job. I've had patients on chronic pain medication for many years. And again, the opportunity to see them in person means that I can perform real medicine and not just a simple recertification and a reissue. The other thing the other problems is you cannot actually touch the patient, you cannot do neurological testing, you cannot listen to their heart and lungs, you can't do vital signs, you can't see if their pulse oximetry is low. So again, I do not feel that it is within the standard of care for a controlled drug opiate controlled 2 to have telemedicine. I used to do telemedicine for controlled 3. It was unsatisfactory. And in addition, at the VA, controlled 3 drugs were occasionally done by pharmacists, their certification. I'm also concerned that paramedical professionals are really not qualified to treat patients for chronic opioid use, and yet different states are relaxing the standard, such that in Florida, nurse practitioners can prescribe up to 7 days for acute conditions. They can prescribe for hospice patients, physician assistants can prescribe. There is no requirements for supervision by an MD. They are independent practitioners. So I do not believe they have the training and the experience to perform telemedicine. The other issue I would say, actually, I used to also do non-drug therapy. I would occasionally do joint injections, refer for physical therapy, and do other treatments such as implementing muscle relaxers, antispasmodics, et cetera, topicals, which I don't feel comfortable doing over telemedicine because I can't examine them. One of the last things in terms of diversion, I have done 2 things in my practice to prevent diversion, which I think should be publicized. One, for fentanyl patches. I have required patients on fentanyl patches, once they take a patch off, to slap it on a piece of paper and date the date they removed it. When they come in for reevaluation, they are to present me the paper, which should have 8 fentanyl patches on it that should be dated. Although this is not perfect, it shows that they have not diverted the patches to someone else, or they were really sneaky and took the patches back from who they diverted it to put them back on the paper. So if they don't have 8 fentanyl patches back on the paper, I get very suspicious that they may be diverting it, fentanyl patches. The other suggestion I have, which has not been approved, is to allow pharmacists to do weekly partial drug fills. Not recertification, not renewal, but to allow the pharmacist and the physician to allow the patient to only get a 1-week supply of medication at a time and be able to come back every week to the pharmacist without seeing the physician to get the next week's supply. The requirement is already available, but the pharmacist cannot bill the $2 and so dispensing fee, which makes it difficult. It would be advantageous to the pharmacist. They would have a better idea of who is coming in because they would expect the next 3 weeks of a 4-week prescription to be there. It would cut down the number of drugs in the house on the street for any given patient by 3/4. They would only have 1 week's supply of controlled drugs at any given time, which makes it harder to divert, harder to steal, harder to overdose. In addition, they get extra supervision by the pharmacist. And for the pharmacy, they also have the added benefit of having to walk through the pharmacy and possibly buying other things for the pharmacist. So I think encouraging partial weekly drug fills. I write a prescription for 120 Percocet. The first week, the pharmacist gives 30. The patient comes back next week, he gets another 30. The third week, another 30. The third week, another 30. The pharmacist will keep the records. I don't have to do it. My prescription is still for 1 month. So I think partial drug fill weekly would significantly help the overdose possibility and get a large number of prescription drugs off the street, encourage patients to come into the pharmacy more often. They still have to come into the pharmacy, even with telemedicine, but the opportunities that are missed, including drug screens, physical examinations, alternation of treatment, review of other practitioners, particularly surgery, physical therapy states, and the opportunity to do point of care labs. Again, I have had at least 4 patients die from drug overdose. One was deliberate, where he had 3 different physicians prescribing 3 different drugs. That was not found easily at autopsy. Another one had an incidental possible overdose that was botched on autopsy. The other 2 were never investigated properly. So I've had that. I've had patients on various drugs. So in summary, I am opposed to telemedicine renew of medications that are controlled to narcotics, but I encourage the telemedicine review and prescribing of controlled to attention deficit disorder drugs and other psychoactive non-narcotic drugs. Thank you.
Thank you, Dr. Berger. I'm looking over at Tom. I do not see that he has any follow-up questions. So thank you. And we will now move on to virtual presenter number 9.
Hi, good morning, everyone. My name is John Heaphy. That's spelled JOHNHEAPHY. I am the Deputy Director of the New York State Bureau of Narcotic Enforcement. I have the privilege of speaking to you today as the voice of New York State on behalf of the New York State Department of Health, the Office of Addiction Services and Supports, and the Department of Mental Health. I would like to thank the DEA for providing stakeholders with the opportunity to contribute to the discussion regarding the telemedicine prescribing of controlled substances. The pandemic precipitated a rapid expansion of telemedicine, which has benefited many across the country. These practices have contributed to health equity for many underserved populations, and we believe there is a role for continuing telemedicine prescribing of some controlled medications. Evaluation should continue, and the Centers for Medicare and Medicaid Services should issue guidance with particular attention to health equity, as there remains a risk that some more vulnerable populations may be inadequately served. With that said, the Drug Enforcement Administration had posed several questions regarding the practice of telemedicine, and I will address those now. The first asks what framework would be recommended if telemedicine prescribing of Schedule 3 through 5 medications were permitted in the absence of an in-person medical evaluation. It's important to begin by addressing medications for opioid use disorder. The clinical significance of both buprenorphine and methadone in the treatment of opioid use disorder has been well established. While there are currently limitations on the prescribing of methadone for this indication, which New York State believes should be reevaluated, we have seen success in telemedicine-initiated buprenorphine. This practice should continue as it did during the pandemic to allow synchronous audio and audiovisual interactions. Best practices are still evolving, and we believe these should be shaped predominantly by evidence-based medicine. If telemedicine prescribing of Schedule 3 through 5 medications other than buprenorphine were permitted in the absence of an in-person medical evaluation, New York State recommends the following. Practitioners must be registered to deliver, distribute, dispense, or prescribe controlled medications in the state where the patient is located, and they must maintain compliance with federal and state laws when delivering, distributing, dispensing, and prescribing a controlled medication. The United States Department of Health and Human Services should be called upon to issue guidance on which conditions can be managed appropriately by telemedicine, as the diagnoses and treatment of those conditions will rely on history rather than physical examination. The primary safeguard in the practice of medicine is appropriate documentation, and the federal government could standardize this component. The telemedicine consultations should be synchronous, audiovisual, with the exception of continuing the option of initiating buprenorphine allowed through synchronous audio-only consultation. However, it is important to consider the potential risks of permitting audio-only telemedicine against the possibility of creating further health inequities or an increased risk of self-medicating due to lack of access to buprenorphine. And this is especially dangerous considering the increased presence of counterfeit medications currently available. Prescriptions should be issued in electronic format to reduce the risk of fraudulent prescriptions. The prescription drug monitoring program should be consulted prior to prescribing to reduce the risk of duplication or patient interactions. States should monitor the prescription drug monitoring program for changes in prescribing patterns and monitor data on morbidity and mortality related to medications obtained pursuant to telemedicine encounters. DEA posed a similar question as it pertains to Schedule II medications as well. If telemedicine prescribing of some Schedule II medications were permitted in the absence of an in-person medical evaluation, we have the following recommendations and considerations in addition to those previously stated. Stimulant treatments for youth with ADHD should be considered. National data on youth mental health show poor mental health outcomes and increased school disconnectedness. Restricting access to evidence-based treatment for ADHD is likely to further increase poor outcomes. Additionally, while the federal government is making significant investments in school-based mental health, there are not enough child psychiatrists, pediatricians, and other prescribers to provide in-person services. Allowing for stimulant prescribing for youth with ADHD with a complete psychiatric evaluation by audio-visual telehealth will have a tremendous impact in ensuring that youth receive timely and appropriate treatment while expanding access to care. Safeguards should include obtaining guardian consent when prescribing to youth and possibly limiting the types of practitioners who may prescribe by telehealth. For example, limiting it to board-certified child and adolescent psychiatrists or pediatricians, or other practitioners that have a supervisory relationship with board-certified child and adolescent psychiatrists. And lastly, DEA should include a component covering stimulant prescribing and stimulant use disorder in the required 8-hour course, which was instituted by the Medication Access and Training Expansion Act of 2021. The final two questions posed pertain to data collection by practitioners and pharmacies. There's a great deal of data collected on Schedule 2 through 5 medications, including prescription drug monitoring program data, insurance company data, as well as private companies that collect health information and make it available at a cost. Practitioners and pharmacists should not be asked for more data specific to these medications, except for the following. The National Council for Prescription Drug Programs, or NCPDP, script standard includes a field to indicate that a prescription was issued by telemedicine, and this field should be utilized. The DEA has historically issued location-specific DEA registrations to practitioners. Continuing this practice will indicate the practitioner's location when a telemedicine prescription is issued. Telemedicine practitioners could be required to submit the name of the telehealth practice or company that they are representing. Additionally, we do not see a role for requiring registration beyond the current standard DEA registration. The former X-waiver DEA registration illustrates why this isn't necessary. History shows that the requirement for a practitioner to have a special registration to provide buprenorphine was a deterrent to sound medical practice, and to our knowledge, did not provide useful safeguards or data. However, if a telemedicine registration is required, then we do recommend that telemedicine registered practitioners should submit aggregate data on the number of prescriptions in each schedule and/or medication class prescribed. This, of course, should not include line-level patient-specific data due to confidentiality concerns. In closing, we recommend that further regulatory changes be considered beyond today's discussion. As mentioned previously, access to methadone for the treatment of opioid use disorder is currently limited solely to opioid treatment programs, and as such, research on the ability to prescribe methadone for opioid use disorder is limited. New York State encourages new pathways be explored to increase research on this issue and allow for improved access to utilize methadone for opioid use disorder. Thank you again for your time and the opportunity to speak today.
Could you elaborate on, you made the comment that the states would monitor. So you talked about the EPCS format, the PDMPs, and then you said states should monitor morbidity and mortality. What would that monitoring be, and who would, like, what is that report going to do?
We believe that if states were to utilize prescription monitoring program data in coordination with vital statistics such as morbidity and mortality, we would be able to analyze the impact that telemedicine prescribing of controlled substances is having on fatal overdoses and overdoses in general.
But you did say that you don't feel that there needs to be a special registration, so how would you know that it was a telemedicine encounter?
I indicated in my
plus,
talk that the NCPDP field should be utilized, which indicates the origin of the prescription, which would be telemedicine in this case.
and how would that be marked on the prescription?
There's a field that is transmitted through electronic prescribing in the NCPDP script standard, which would indicate telemedicine prescription. That data would be captured, could be captured by the prescription monitoring programs if that field is required to be submitted.
So this data that would be collected, this would be just monitored by the states. Would there be any coordination with DEA or law enforcement?
That would be up to DEA purview. Our current recommendation is that it's collected at the state level.
Okay, thank you.
Thank you.
Okay. Thank you, Mr. Heafy, for your comments, and we will now move on to virtual presenter number 10.
Hello, my name's Philip Moore. I'm the Chief Medical Officer for Cadenzia. My background is internal medicine, addiction medicine, and medical toxicology. Cadenzia is the largest nonprofit provider of treatment for people with substance use and co-occurring disorders in the Northeast. Cadenzia has been treating people for the past 54 years in 50 locations, and we have 100 programs in Pennsylvania, Maryland, Delaware, and Washington, D.C. Our largest footprint and our corporate office is in Pennsylvania. Last year, we served over 15,000 people. And our stance, Cadenzia strongly endorses the permanent integration of telehealth for Schedule 3 to 5 drugs, which was established during COVID. The way we were able to develop these telehealth programs, our facilities created the infrastructure where our patients would come in for counseling, they'd come in for urine drug screens, and they would receive injectable medications such as extended release buprenorphine, and they would receive this from nurses when a physician or advanced practitioner was not on site. We were able to create a rotating schedule where a prescriber rotated around between multiple sites, and we offered telemedicine using encrypted audio-video platforms with multi-factor authentication. And what our program allowed us to do was to bridge MAT and mental health treatment until our patients could transition from our residential facilities to community providers, or would allow us to really maximize who we could see at our rural locations that may not have a licensed prescriber 5 days a week or 7 days a week. We were able to pair the MAT with counseling instead of just offering counseling alone at a significant increased number of facilities. So we were able to reduce barriers to care for people living in rural areas without consistent, convenient access to care. We were able to increase the accessibility for people with disabilities who have reduced access to consistent substance use care. We were able to maximize access to physicians for vital medication-assisted treatment, induction, and maintenance in both our residential and outpatient settings. More about the residential is the telehealth allowed us to expand access to start MAT for individuals starting treatment. Our facilities are 24-hour, and we might not have a prescriber in the facility all 24 hours of the day. So if someone comes in the evening, we have a small window of time before they start going into withdrawal, and telehealth really helped us to improve our retention in treatment so that people were staying, much longer than 24 hours. So our endorsement is rooted in a belief that vital substance use disorder treatment, including medication-assisted treatment, should be available for all those who seek it and when they seek it. We found that there's a small window of time to start these medications when someone requests help. This is because modern drugs and their use have been associated with the development of withdrawal symptoms faster than what historically occurred. Most recent data from the NIH and CDC reveals a concerning statistic. Just 1/5 of nearly 2.5 million adults grappling with opioid use disorder received medication-assisted treatment in 2021. Returning to the pre-COVID regulations, which mandated in-person evaluations, could significantly compound access challenges, especially in rural and underserved areas, which leads to increased relapse and overdose rate. During the pandemic, it really underscored the significant value of remote care, especially with substance use disorder treatment. Cadenzia's outpatient sites, in particular, harness the flexibility and accessibility to telehealth to increase MAT services to the majority of the agency's outpatient sites and facilitate access to MAT for over 450 outpatient clients since May of 2020. We were able to add 10 additional outpatient sites in the last year or last year and a half because of telehealth. So telehealth has permitted the flexibility, improved access. It has not jeopardized safety and accountability, with counseling and nursing staff playing an essential role in monitoring and ensuring continued engagement in treatment. We understand that these changes can only be made permanent with a meaningful framework, which is what we strongly encourage, is that telehealth is only offered by facilities that have the appropriate infrastructure to monitor for diversion and safe prescribing. Considering the patient's safety concerns and the imperative of preventing controlled substance misuse, Cadenzia recommends enhancing patient identification, verification, and monitoring protocols alongside establishing tailored guidelines and standardized training specific to telemedicine practices. We recommend continuing the access to telehealth care that includes all forms of MAT treatment when it's closely monitored, and we feel this will continue to improve necessary access to these life-saving medications and care for persons with both substance use and co-occurring disorders who might not be able to access healthcare in the traditional methods. Removing this much-needed flexible tool could have significant negative effects on the opioid and addiction epidemic, which we are all working so hard to stop. In summary, telemedicine should be a viable option for facilities and prescribers that have demonstrated a capability to safely manage with the appropriate infrastructure to minimize diversion for Schedule 3 through 5 medications. And I really appreciate the opportunity to speak today.
Could you expand on your thoughts on the patient ID? Either what you do or what you are suggesting on that?
So using telehealth, if they're using multi-factor authentication, and if they're using their appropriate their corresponding name, that helps make sure that you are speaking to that individual, and then also once they're on the line, have a way to confirm their identity, their name, and something like a code word, or last 4 digits of a number, something so that you're allowed to, or that you're able to more accurately verify it is who you're supposed to be speaking with. Similarly to when someone comes into an OTP, and you're verifying their identity by looking at a picture that's been scanned into the system, and you have a copy of their driver's license, and they give you a 4-digit number or some kind of word to also help identify who they are. That's what we tried to build into our telehealth platform.
And medically, what else do you see as this meaningful framework that the provider would do in their evaluation?
As far as like what structure we built that they're evaluating during the initial and follow-up visits?
Specifically the initial visit. Like what medical steps is that provider taking to ensure that they know they're assessing the patient properly?
So all our patients, we have a workflow for intake, and the intake or admission assessment is completed by multiple individuals. So part of it will be in a facility. Part of it could be remote by telehealth, but they the same things are completed as far as demographics, obtaining a copy of their insurance, their photo ID. They we complete an insurance verification. We complete things from depression screener to Columbia suicide risk assessment. There's a nursing biopsychosocial. There's also a counselor or clinician intake. The prescriber would review all of these documents, and then individually confirm a history, of course their identity, and then with all this information, which would also include a urine drug screen, which we require to be collected within 7 days of an admission in our outpatient program. And as well as checking a prescription drug monitoring program report. So with all that data, our licensed physicians or advanced practice practitioners would make a decision about the appropriateness for outpatient treatment, or in some circumstances they might recommend residential to start, then eventually stepping down to outpatient. Does that answer your question?
Yes, thank you.
Okay. All right. Well, thank you very much, Dr. Moore. I am being told by the production crew that we have 2 more virtual presenters for our morning session. So we will now move on to virtual presenter number 11.
Thank you very much. I'm Jesse Ehrenfeld, Dr. Jesse Ehrenfeld, an anesthesiologist and president of the AMA. It's Jesse, Jesse, Ehrenfeld, Ehrenfeld. The American Medical Association really appreciates the DEA hosting this public listening session to help inform your regulations on prescribing controlled substances via telemedicine. We want to commend the DEA for taking additional time to ensure that your rules provide an appropriate balance between advancing patients' access to care via telemedicine and ensuring patient safety. I want to first comment on Schedule 3 through 5. The COVID public health emergency demonstrated telemedicine prescribing of Schedule 3 through 5 medications with and without an in-person evaluation help patients with many medical conditions begin and maintain necessary care. Whether it was audio only, audio-visual, or in-person care, physicians provide high-quality, evidence-based care that relies on thorough assessments and sound decision-making. So for example, during the COVID public health emergency, audio-only and audio-visual telehealth induction with buprenorphine for opioid use disorder was extremely helpful for maintaining continuity of care and preventing relapse for those currently receiving treatment with medication for opioid use disorder. We strongly urge the DEA to ensure that access to medications for opioid use disorder is not interrupted through new requirements that might impose a barrier to care. There are many safeguards that currently exist through state law as well as the Controlled Substances Act that provide a sufficient framework to help ensure patient safety and prevent diversion. The professional, the ethical, the legal obligations that govern the practice of medicine and pharmacy can and should be trusted to provide ample safeguards for ensuring patient safety. If a prescription is not issued for a legitimate medical purpose, it should not be dispensed. This applies regardless of the modality used for patient evaluation leading to the issuance of the prescription. Another key safeguard is that every state requires controlled substances to be entered into the state prescription drug monitoring programs when they are dispensed. This information provides physicians and pharmacists with helpful clinical information, including whether patients are obtaining prescriptions from multiple prescribers and pharmacists. If the dispensing pharmacist has questions regarding whether a prescription for a scheduled medication is for a legitimate medical purpose, or has other questions, it is common for the pharmacist to talk with the patient, contact the physician, or seek other information to try and resolve the questions or determine that the prescription should not be dispensed. These processes and relationships help ensure patient safety as well as protect against diversion. The framework for prescriptions issued based on a telemedicine encounter must also allow patients sufficient time to schedule an in-person visit when clinically appropriate. The AMA urges that following an initial telehealth encounter, the patient be afforded at least 6 months to fill and renew prescriptions before being required to have an in-person visit. This can help ensure that the patient is stable on the course of medication therapy so that the in-person visit can be a seamless transition. Having at least 6 months as a part of the framework for prescribing Schedule 3 through 5 controlled substances via telemedicine addresses multiple current barriers. These barriers include health insurance network inadequacy, functional limitations that can make access to in-person services difficult, long travel times, racial disparities in access to buprenorphine versus methadone treatment, long wait times for treatment, the need for a caregiver to accompany the patient, stigma within the medical community regarding drug users, and patients experiencing unstable housing and lack of transportation or childcare. Telehealth visits for opioid use disorder have helped many patients access treatment, including buprenorphine. Now let me mention Schedule 2 medications. The AMA continues to support telemedicine prescribing of Schedule 2 controlled substances in the absence of an in-person medical evaluation when clinically appropriate. A telemedicine prescription can help ensure that the patient receives timely therapy without delay, including for patients with chronic medical conditions, cancer, in hospice, those living in remote or underserved area, or other situations. The AMA does not support sham practices that have no assessment, evaluation, or other markers of legitimate care, but the COVID public health emergency demonstrated that physicians can and do thoroughly assess a patient via a telemedicine counter. This includes determining whether a prescription would be clinically appropriate during an initial telehealth visit, or for current patients, telemedicine can allow a physician to conduct pill counts, monitor toxicology screens, and ensure medication adherence or identify aberrant behaviors requiring a change in therapy. For situations where an in-person evaluation would result in a delay in care that could lead to patient harm, the AMA urges that telemedicine prescribing of Schedule II medications be permitted. When a telemedicine visit is scheduled or started, the physician does not know how complex the patient's illness or injury is, or what medication or medications may be most appropriate to treat the illness or manage its symptoms until the visit's been completed. It's equally true that not all care can be provided via telehealth, a lesson we have learned well. If a physician determines during a telehealth visit that the patient needs to be seen in person, that should be the next step. The AMA cautions DEA about making new rules allowing only some controlled substances to be prescribed based on telemedicine visits. If at the end of a telemedicine visit, the complexity of a patient's medical condition warrants a prescription for a medication that is not on some approved telemedicine list, the physician's options will be to prescribe a non-optimal treatment or to attempt to arrange an in-person appointment so they can prescribe the appropriate medication. This includes Schedule II medications. The AMA urges a targeted enforcement strategy to deal with illegal online practices rather than new rules that would adversely affect practices that provide high-quality, evidence-based care to patients with medical conditions benefiting from Schedule II controlled substances. Safeguards already exist in the Controlled Substances Act and state licensure governing medical and pharmacy practice. The AMA recommends that where it is suspected that the standard of care is not being met and diagnostic integrity and accuracy may be compromised, medical boards pursue focused oversight to ensure appropriate patient care and prescribing of controlled substances. If there is illegal activity, law enforcement intervention may be necessary as well. The COVID public health emergency forced physicians to adopt new ways to ensure evidence-based, high-quality continuity of care and increase access to care for patients with chronic conditions. We met that challenge. Our patients benefited. We supported the administration's efforts to extend the PHE flexibilities, and we similarly urged DEA not to reverse practices that are now helping patients. Let me just mention a few other data points. The framework moving forward should avoid a new burdensome record-keeping requirement. We are concerned about the DEA's proposal regarding records being maintained for investigation purposes. Current DEA requirements for records related to prescribing and dispensing of controlled substances should be sufficient if the DEA needs to conduct an investigation. The DEA already receives a tremendous amount of data from manufacturers, distributors, pharmacies about controlled substances in the supply chain. These entities are required to provide DEA with suspicious order reports to help identify potential problem areas. State PDMPs contain personal health information regarding individual prescribers and patients that is clinical in nature and should not be shared or disclosed to law enforcement without probable cause. DEA has the ability to seek judicial approval for accessing a PDMP or conducting other surveillance activity. We do not believe the DEA needs more data to strategically target illegal activity, and we would be concerned if DEA proactively sought state PDMP data as a part of data mining or routine surveillance activities. Thank you very much for the opportunity to provide these comments on behalf of the American Medical Association.
You mentioned a targeted enforcement strategy. What does that mean?
It means when you have a signal that there's a problem, that you look at those practices that have an aberrant strategy going on, and you look at them with scrutiny.
Okay.
As opposed to taking a blunt approach through a regulatory framework that ultimately causes more harm than good.
And where did I have it here? I missed one of your, after the 6 months, the framework that you had. I had check insurance, travel times, long wait times, and I didn't get that. What was the fourth one? Stigma was the one after that.
When I was mentioning the framework, there are a lot of barriers to people accessing in-person care. So health insurance network inadequacy, functional limitations that can make access to in-person services difficult, long travel times, racial disparities in access to buprenorphine versus methadone, long wait times for treatment, the need for a caregiver to accompany the patient, and stigma within the medical community regarding drug users and patients experiencing unstable housing, lack of transportation, childcare are the barriers that we wanted to highlight.
Thank you.
Great. Thank you, Dr. Ehrenfeld. And I do want to just make a point of clarification, and it bears emphasis because I know that this, I think, is a fundamental assumption or perhaps misunderstanding about our rule or the draft rule that was published in March. And as Ann Milgram mentioned on day one in her introductory remarks, the Ryan Haight Act amended the CSA and required an in-person visit be established, and then created an exception to that requirement when the practice of telemedicine was occurring, right? And then the statute then listed 7 or 8 different circumstances that constituted the practice of telemedicine. So one thing that we make clear in our rule and the nature of our rulemaking forthcoming is that when there is already an in-person relationship that has been established, this rule does not in any way, shape, or form somehow impose a new requirement on the types of controlled substances that could be prescribed, the duration of the controlled substance that is prescribed, and the instance in which a patient must then come back and visit the practitioner. And it just bears emphasis because I think we don't want to lose in our translation the fact that this rule is not being applied broadly to all telemedicine counters across the entire spectrum, whether that in-person relationship has been established or not. So I just wanted to make that clarification. I appreciate Dr. Ehrenfeld's comments, and we will now move on to virtual presenter number 12, which I believe is our last presenter for our morning session. Thank you.
Hello, everyone. My name is Delphine Huang. That's Delphine. Last name is Huang. Thank you so much for taking the time to hear some of my thoughts and comments. I'm coming as a representative of CalMESA, which is the California Mental Health Service Authority. We're a joint power of authority where we work with Medi-Cal counties across the state of California as a collaborative multi-county projects that improve behavioral and mental health for patients that are Californian and from Medi-Cal. We work together with them to pool kind of resources, think about partnerships and leveraging the technical expertise, and think about the strategies. My particular role, I'm a medical director of innovation and design. While a physician, I'm actually responsible for thinking about the user experience and how different services or technologies are implemented. Today, I wanted to share just some perspectives and mostly raise some questions around for just us to think about, where I'm curious when it comes to prescribing. I think along with other colleagues that I've heard here today, prescribing our resource limited populations, which many of our Medi-Cal patients are facing. So we wanted to understand better from the DEA what are some issues around prescribing controlled substances in a telehealth environment and the impact for vulnerable as well as resource limited populations, especially in rural areas where there are really limited numbers of doctors available. In some of the Medi-Cal counties that are rural, we actually only have 1 to 2 child psychiatrists or 2 to 6 adult psychiatrists that will be serving the entire county in order to, and they use telehealth as the only means to have the expansive reach that they do. We are also seeing a workforce crisis in mental health currently, where we have declining numbers of doctors and/or prescribers due to other competitions for doctors working in private or for Medicare, as well as an aging provider population. This actually makes it very difficult to recruit and retain talent. We have several counties that have a difficulty even recruiting their one-child psychiatrist because they actually, as a Medi-Cal county, will be required to provide in-person services and therefore must hire locally. So we're curious to hear from the DEA, what support, if moving forward for these requirements, whether the HIE and data sharing access that they're going to support, especially around flags and notifications. Currently, we are Cal Mesa has a EHR that we rolled out in July across 22 counties as a semi-statewide EHR, and other counties are also coming on board. We have taken upon ourselves to create fields where we can track whether or not doctors are reviewing cures, and they can report that. But we're curious to hear, because many of the things that they are also requesting for in the EHR is ways in which they can integrate with cures and get notifications, as well as kind of local and population health, in order to support their work, which they believe is the importance of tracking prescribed controlled substances. We have also created ways within the EHR to think about med reconciliation, as well as identification of the patient. I'm curious to hear from the DEA what exceptions might be made, especially around some of the things that folks are raising here, which is around given the patient population, especially our Medi-Cal population, which may have difficulties both with transportation and getting themselves into an inpatient appointment. Really where we see some of the issues are when it comes to how patients are using their controlled substance is really around that piece around data, how data is captured between the visits. If you think about the visit being only a 15-minute moment of time, what is happening between those visits are actually more important when it comes to patient safety, patient outcomes. The second area that we would love to understand better from the DEA is understanding around CF42 and both the need to respect privacy or patient privacy, but also the need for data sharing transparency for making decision-making about prescribing controlled substances, especially around substance use disorder providers, SUD, and the mental health and medical. So as I mentioned, that with the EHR that we have launched across our 22 counties and expanding more, there has been a lot of discussion around CF42 and how this has led to siloed prescribing. And so want to understand better from the DEA how they consider the CF42 that currently exists and what it means when it comes to telehealth and data sharing across different providers. We do think it's really important when it comes to especially controlled substances, given the risk, to maintain that transparency in order for your providers to be able to have clarity on the diagnosis, the clinical decision-making, as well as the medication. So once again, thinking about what it means when it comes to HIE and data sharing, when it comes to these prescribed controlled substances, and then thinking about how you're tracking patient movement across different siloed systems that currently exist, given that while we are moving towards having a universal EHR, this is still very difficult when we are not necessarily connected to the medical side, and then therefore if we're thinking about it from a telehealth perspective, these patients may be coming in, may have difficulty coming to their appointments, and therefore follow-up is very tough to get that information from the patient. That's all my comments here today, more so providing kind of questions to the DEA to learn more around the CFR42, as well as thinking about how we build accessibility for resource-limited populations that also have very limited access to a small workforce. Thank you.
Thank you, Dr. Huang. And I believe that we may have a question, or do you have a question, Tom? Okay. It does not appear that we have a question for you, so thank you for making time for us. And I think we are now going to conclude our morning session. We will resume our afternoon session at 12:40. I do know that our Administrator Milgram will be back for the 12:40 session. I thank everyone on the virtual side for presenting, and those that are watching the live stream. Thank you for attending, and of course, all of you that are here in the audience today. We'll see you at 12:40. Welcome back from lunch, everyone. Thank you to our in-person commenters who were here early and so patient waiting as we walk through our virtual comments from our morning block. As I indicated, we will now be starting our afternoon block of in-person presenters. I'm happy to report we have Administrator Milgram back for our afternoon presentations, as well as Assistant Administrator Provoznik. So without further ado, we will go ahead and call to the stage commenter number 1. I'll just give a friendly reminder to all our commenters, if you would state your name and your affiliation, and then spell your first and last name for our transcribers.
Thanks, Matt. Welcome back, everyone. My name is Danielle Vaith. That's spelled D-A-N-I-E-L-L-E, last name V-A-E-T-H. Thank you for the opportunity. I represent QB Tech, a privately held medical device company that has dedicated the last 15 years to providing FDA-cleared evidence-based tools to improve assessment and treatment monitoring for clinicians dealing with ADHD. I stand here today in alliance with DEA, ATA, AMA, ABHW, ADA, an ADHD patient advocacy group with more than 6,000 adult members, and many others, for the importance of data-driven and equitable access to telehealth services. We stand that telehealth is health, that mental and behavioral care is health care, and to reiterate Kyle Zepley's comments, that all should be regulated on a level playing field, regardless of whether in-person or virtual. We appreciate the opportunity to promote better safeguards for telehealth and in-person visits, particularly when it comes to prescribing medication. I've been at QB Tech for just under a decade and personally have heard from hundreds of clinicians and want to reiterate that the thousands of people, including patient stories, particularly that of later in life adults like Dr. Teddy or Mom Lori, who we've heard from over the last 2 days, are not unique. I must highlight that ADHD access is a public health issue, not just a private one, and was reminded by expert in the field, Dr. Tony Rostein, this morning, that none of the science and effort in advancing the field is truly meaningful without access. Based on our experience with over 12,000 clinicians globally, we believe that companies and clinicians should consider adding a level of protection for practices that is not yet widespread in the US. Leveraging data better informs treatment and enhances patient outcomes, which includes those receiving care for ADHD, a most treatable behavioral health condition. My aim is to share how prescriptions via telehealth along the care continuum can be considered alongside FDA-cleared objective measurements, ensuring precise dose optimization and mitigating overtreatment. Quality, measurable data that can safeguard virtual prescribing practices is currently available and utilized by thousands of clinicians nationally. By way of introduction, QB Tech, an FDA-cleared medical device, has been available to U.S. practitioners since 2012. It offers a simple and computer-based test that measures hyperactivity, attention, and impulse control. The test can be conducted at home or in a clinic and is interpreted by a trained, qualified health professional. By comparing a highly visual report, incorporating robust data against age and sex controls, clinicians can ensure that the right patients receive the care that they need. The same test is used to measure symptom changes before and after treatment of any kind, often, as we know, with Schedule IIs, to ensure effective symptom improvement. Our experience has been that many patients and parents and clinicians alike lack certainty, confidence, and clarity when it comes to both their diagnosis and decisions around treatment. It is often a misunderstood condition, both over and underdiagnosed. It is a condition that is underserved in medical training programs. For example, 93% of psychiatry residency programs do not include formalized training in ADHD. Ill-prepared to accurately assess these patients, clinicians search for objective data to aid diagnostically as well as to quantitatively measure response to treatment and to better titrate medication dose. I not only represent QB Tech, but the clinicians we partner with, including a clinical and community advocate team, the ADHD Expert Consortium. This group created a call to action statement for increased clarity, advanced education, tools, and resources for which they have almost 900 signatures. Their statement underscores the critical need for data-driven care. The group includes the likes of pediatrician James Wiley in Alabama, who, while educated and resourced on the topic, struggled to find an accurate assessment for his own daughter, who was initially incorrectly diagnosed with a learning disability. These clinicians add objective data to their care pathway because ADHD is a chronic, prevalent condition. It is one of complexity, where management takes nuance. A study by Vach Shimelli showed that QB Tech computerized objective data could not only identify treatment response in 84% of patients, but could also separate those with a partial response from those who are non-responders. This is a pivotal moment in our history where we can continue to provide equitable access, evidence-based tools, and safeguards that have been extended in already overburdened system. We believe hybrid models of patient care are necessary, but need to keep in mind that ADHD has a unique burden in this model as a chronic and complex condition with high prevalence rate, treated commonly with Schedule II medications, and that this is a condition which can be missed. Today, we hope to shed light on the role FDA-cleared technologies in ensuring that quality ADHD care can be delivered regardless of the delivery model. Measurement-based tools are providing clinicians with objective data on symptom severity and treatment response, better informing clinical practice, providing accountability, and facilitating safer prescribing practices without the need for an in-person visit. Prescriptions based on data points looking at efficacy as well as time of day help to add safeguards around controlled substance dispensing and to standardize a more stepwise process. Our success extends globally. We have a proven track record in countries that are already prioritizing evidence-based objective data into their pathways. Our testing system is now a standard of care within the National Health Service in England, where 70% of NHS clinics are routinely using QB Tech testing, which after 3 years of study and 70,000 patients, we received a nice appraisal this past March. We now serve over 4,000 clinicians in the US in varying size and geographic locations, from FQHCs and universities to health systems and private networks. We know the need for mental health care virtually has increased since the pandemic. ADHD evaluations and treatment, especially among adults, surged 400% since 2020, while the supply of qualified healthcare providers remains stagnant or sadly decreased. After 5 years of study, QB Tech launched an FDA-cleared remote testing platform, ensuring that quality of ADHD evaluations and medication monitoring remained uncompromised for remote patients. So clinicians like Heather Brannon, a doctor in rural South Carolina, could continue to monitor medication efficacy without compromise just because her patients were receiving care remotely. To date, we have tested more than 70,000 patients using a virtual QB test. Our robust quantitative data and highly visual reports are incorporated into clinical interview and patient report of symptoms. Qualified healthcare professionals are trained by our master's level mental health clinicians. In 2023, we conducted over 6,500 training episodes in the US, ensuring that clinicians are well equipped to interpret and utilize our data effectively. These clinicians all use testing as a part of their assessment process. Additionally, when it comes to initiating a treatment protocol, particularly for Schedule II medications, many clinicians will conduct a repeat testing on treatment to monitor results over time. Depending on the type of treatment and time of day, the clinician may be looking at efficacy, type, dose, class, or consideration of wear-off. This data is then utilized in context of interview and self-report to guide next steps. FDA-cleared objective measurements ensure precise dose optimization and can mitigate overtreatment. Objective data should be recorded at each medication change as available, along with evidence of patient benefit, efficacy, and to mitigate diversion. Many clinicians monitor effectiveness long-term every 6 months to look at changes over time or across the day, both with subjective self-report and objective testing data. Real-world examples and study data similarly confirm the efficacy of QB Tech's objective data in measuring treatment response. A study published in 2022 out of North Carolina, where patients completed a self-report and our testing, were followed up with their clinician at 6 months. When looking at the patient self-report data alone, 36.6% of adults reported improvement. Yet when analyzing their QB Tech results, 85.5% showed a measurable change on their treatment. demonstrating that self-report alone misevaluated over 50% of patients, or 50% of patients were missed with self-report alone when it came to treatment response measuring. Meaning that when employing FDA-validated tools, we're leaving less subjectivity when it comes to measuring if treatments are working. This could lead to clinicians and patients agreeing on changes in dose or medications that were unnecessary. Our data shows that QB test, when used to monitor treatment response, can distinguish a treatment effect within hours of pharmacological treatment if prescribed a stimulant, meaning clinicians and patients have additional data around treatment decision-making and can further be used for monitoring long-term treatment effect. Pediatrician Dr. Melinda Willingham, a member of our expert consortium who also serves as a representative for the AAP on the Committee for Federal Government Affairs, who uses QB test to serve an unserved community outside of Atlanta, she describes as a care desert, shared this. In today's evolving healthcare landscape, telemedicine presents a unique opportunity to harness rich patient data to advance precision care. By considering data as a vital component in both assessment and treatment response, we empower healthcare providers to tailor interventions with greater accuracy, elevate the standard of care, and ultimately improve patient outcomes. In conclusion, telehealth is healthcare and is providing more people with necessary care. We have the ability to provide equitable and objective approaches to care and ensure accurate screening, monitoring, and clinical confidence, especially in virtual visits, as a safeguard. Together, we can arm clinicians with objective tools and enhance the quality of care for those living with ADHD. I thank you for your attention, and I thank you for your caring. I hope together we can achieve what we've dedicated our lives to doing and making a difference.
Thank you. If I could ask one question, you talked a little bit about, I think you talked about, I just want to make sure I'm tracking and asking you to expand correctly. You talked a little bit, I think, about the guidelines for prescribing, and I think I would love for you to expand a little bit on, are there sufficient prescribing guidelines for ADHD for children, and are there sufficient prescribing guidelines for ADHD for adults?
I think I'll leave that up to the clinical community to comment more. I know that AAP and SDP, the Society for Developmental and Behavioral Pediatrics, have clinical care guidelines around treatment. The adult guidelines are being built right now by APSARD, which is an organization I'm a member of, but I think there is clarity. Mm-hmm.
Sorry about that. Could you just expound on, you said that there was research platform testing of 70,000 patients. Could you,
No,
what was that?
We've tested over 70,000 patients in our virtual platform.
And is there results of that testing? What has it shown?
Those are the number of people who've had access to our testing via virtual. The data, if you have specific questions about the data and treatment response, we've got 15 studies looking at treatment response measurement, varying in terms of length and duration, time from looking at efficacy, time of day, for instance, wear off, those types of things.
Okay, thank you.
Okay, commenter number 2. Thank you.
Good afternoon. Thank you very much. My name is Stephen Martin, S-T-E-P-H-E-N, last name Martin, M-A-R-T-I-N, and I'm with Boulder Care, and I will also spell that because it is B-O-U-L-D-E-R Care. Thank you so much for this opportunity to share comments on behalf of Boulder Care. We are a Joint Commission-accredited telehealth organization caring for people with opioid and alcohol use disorders since 2017. I have served as Boulder's medical director for research, education, and quality since early 2019. After attending medical school at Harvard and residency training at Boston University, I became a family physician and addiction medicine specialist. For nearly 20 years, I have provided in-person primary care in rural Massachusetts, where I'm also a professor of family medicine and community health at UMass Chan Medical School. I came to DEA headquarters today knowing of your memorial and photographs for some of the people who have been lost to opioids, especially fentanyl. In my rural office above my desk, I have my own photos of health center patients we have lost to overdose as well. I still care for their grieving families. I begin my comments sharing this mutual respect for those we have lost with you, and recognizing we are here together to find the best way forward to help everyone in need. Almost 20 years ago in 2004, I was in my residency training at South Boston Community Health Center. An internist faculty member had just begun prescribing buprenorphine, which was recently approved, and his panel maximum was 30 patients. When that number went to 29, people in the community knew about it before we did. People were desperate for this life-saving medicine, desperate, and we were essentially running a lottery for people to survive addiction to OxyContin. 20 years later, we now have a lottery for people to survive addiction to fentanyl. A major reason is that American primary care cannot take on the complexity of this type of care at the scale that is needed. The numbers speak for themselves. People can't even establish primary care, let alone access just-in-time expertise to care for this life-threatening condition. Even with the X waiver eliminated, researchers and practitioners both acknowledge this is unlikely to change the basic calculus of available treatment. If people can't access buprenorphine through primary care, what are their choices? The outcomes for naltrexone continue to be disappointing, to the point that people have voted with their feet. It is used less than 1% of the time compared with the other two FDA-approved medications. Access to methadone in the US is the most tightly controlled in the developed world and has its own well-described and entrenched obstacles that are doing harm. Unfortunately, they aren't likely to change in the near term. If methadone is not increasing in availability and naltrexone isn't useful, we are left with buprenorphine. As a matter of policy, if this medication isn't readily accessed in primary care, where can it come from? A relatively small number of the estimated 7.5 million Americans with opioid use disorder end up in the emergency department, where, even when they are seen for an overdose, they are prescribed buprenorphine less than 10% of the time. 20 years after the scarcity of treatment I saw in South Boston, this scarcity continues. But we are here together because there is a proven solution of telehealth. Let me tell you a bit about Boulder Care. Since the suspension of an in-person visit in March of 2020, our clinical team has conducted over 50,000 visits on secure video and engaged in 600,000 secure telecommunication touchpoints with several thousand patients. Almost 90% of our patients have Medicaid coverage, the most underserved population in substance use disorders and who have the greatest needs. Over 30% of our patients live in HRSA-designated rural areas, and the vast majority lack transportation. Despite the challenges of being in remote areas, our rural patients have parity in outcomes compared with those who are located in suburban and urban locations, as has also been found by other telehealth providers. 64% of our patients who responded to a March survey said they have significant barriers to in-person care, lacking access to transportation, a nearby health care facility that can treat substance use, or a primary care provider, or a combination of all three. Hundreds of patients reported that they fear losing their privacy and anonymity if forced to seek services locally, particularly those residing in small towns. There is shame and humiliation associated with in-person addiction treatment, and there are related risks of losing employment, child custody, and social standing. Boulder Care is relentless about using data to improve our work, publish research, and share insights freely with others who may benefit. We are held accountable for quality care by dozens of health insurers who reimburse based on outcome metrics. Between 2021 and 2023, through grant funding by the National Institute on Drug Abuse, we conducted a prospective cohort study with our research partner, Oregon Health and Science University, reporting our findings this past June. We found that telehealth-only clinical outcomes were the same or better than treatment as usual. The study found Boulder Care's 6-month retention to be approximately 90%, 3 times the national average for office-based opioid treatment. Another analysis of our clinical outcomes found that patients who stay in care with us for 3 months have a 50% chance of staying with us for more than 2 years. Our data is consistent with a body of peer-reviewed research, including recent reports from the CDC and NIH, that indicate telehealth-only buprenorphine care is safe, effective, valuable to society in the midst of a worsening national opioid crisis. This research also finds that an in-person evaluation is not representative or a proxy for quality health care. I can understand the inclination to associate in-person with increased quality of care, but having been in healthcare for over a quarter century, there's a lot of terrible in-person care and a lot of excellent care at a distance. Having two warm bodies in the same room has nothing to do with safe or quality care. Everything one would want from a public policy perspective, improved equity, health, quality of life, and help for vulnerable populations, is being done with telehealth-only care. As practitioners with decades of clinical experience treating patients and prescribing controlled substances in person and through telehealth, we'd appreciate sharing some recommendations about policies that will impact our ability to provide buprenorphine treatment for adults. We echo prior comments about minimizing burden placed on patients and have ample evidence that a mandatory in-person visit of any type presents a significant barrier many patients will not overcome. We concur with sentiments that regulating clinical entity is preferable to adding requirements for patients. We caution against adding new forms of patient surveillance not supported by medical evidence or deemed necessary by the treating provider, having seen these protocols deter patients and providers for decades. Examples include prescription dosing limits, short-term prescriptions, and frequent drug tests. We ask that the DEA consider the extensive local, state, and federal oversight already in place to regulate practice standards for practitioners. Practitioners are already required to report copious information to licensing boards, state authorities, insurers, and accreditation bodies in order to practice. The DEA can make use of existing data sources for clear quality indicators and warning signs to identify and root out the potentially few bad actors. A special registration, if enacted, should not create unnecessary administrative burdens on telehealth providers with multi-state practices and avoid exacerbating existing challenges to providers. As stated by previous commenters, providers should not be required to maintain physical addresses or locations in multiple states. Lastly, telehealth prescriptions should not be labeled as or red flagged. Pharmacies, particularly certain large chains, have discriminated against and refused to fill valid prescriptions from telehealth clinicians, as described during a SAMHSA two-day meeting last year. Any requirement to label a prescription as telehealth will further stigmatize and restrict patient access to medication. Pharmacist colleagues from around the country are allies in supporting telehealth-based care and do not see a need for such labeling. Earlier this year, we received hundreds of comments from our patients about the hardships an in-person visit would present for them or future patients. With their permission, I appreciate bringing in their patient voice to this listening session. Patient 1, to get the medication I need to live a better life, my 75-year-old mom was actually driving me and another disabled individual almost every week to our last MAT program. Not only would it be traumatic to see a new doctor I'm not familiar with, as a war veteran with PTSD and dual diagnoses, it would disrupt the continuity of treatment. Patient 2, the care I am getting at Boulder is available 24/7. I've utilized their on-call doctor in the middle of the night and can reach my peer support all week. My peer calls back within an hour. My doctor answers my messages within seconds. They've helped me live a safer, better life, helping others and living up to my potential. We should be trying to ease patients' fears and trepidation about getting clean and sober, not making it more difficult. And patient 3, I've been with Boulder going on 2 years. Suboxone care through telehealth has saved my life. My doctor is amazing. Although it is through telemedicine, we have a personal relationship and I have an attachment to her, a real connection. She has supported me more than just through addiction, and my 8-month-old baby has her mom back. Making quality treatment accessible ensures that the right thing to do is also the easiest thing to do. The alternative, purchasing fentanyl on the street for $3 by sending one text message, should scare and inform us. We can prevent diversion and overdose by giving people an immediate link to treatment as soon as they are ready. Telehealth uniquely makes this possible. Lastly, very few healthcare interventions actually scale, maintain quality, and improve equity. Telehealth for opioid use disorder does each of these. It is truly a medical miracle, and it is the only demonstrated solution that can help this administration meet its goal of dramatically expanding quality care for opioid use disorder. We ask that you please ensure conscientious telehealth providers can continue to readily offer and expand this life-saving care as they have for the past 3 years. Thank you for your time and consideration.
If I could, just a couple
Please.
questions.
Thank you.
You so much. To clarify, and I was taking notes, but I
Oh,
might have missed this.
certainly.
So you were talking about the removal of the X waiver,
Yes.
the expansion of the number of providers
Yes.
for buprenorphine. But I believe you were saying that American primary care can't take on buprenorphine, and
Yes.
I would just love to have you expand on that a little bit.
I have a textbook I'm writing. I'm very dedicated to primary care. I think it is probably the best source of care for this kind of work. In Massachusetts right now, if you're in Boston, you can't get primary care for 6 months. And that primary care is not likely to know what to do with opioid use disorder. In other settings of the country, those data are worse. If you have Medicaid, worse. If you have no insurance, worse. And again, fewer than 5% of primary care providers have an X waiver showing interest prior to the removal of the waiver. And the complexity, this is not hypertension. It really is very different. People are living with a life-threatening illness. And we have a dedicated phone number for people on Suboxone, so they can get right to a knowledgeable nurse that hour, that day, that minute. Primary care, unfortunately, just isn't built to do that these days, and I wish it were, and I hope to see it do it someday, but we don't have time. I hope that helps.
Thank you. It's very helpful. The guardrails.
Yes.
You talked a little
Please.
bit about available data, but
Yes.
it'd be helpful to have you talk a little bit about what guardrails you think should exist around telehealth prescribing.
Oh, certainly.
Yeah.
Yes, certainly. Well, I've been through the generation that came through the prescription monitoring programs, and the data that are available there are quite robust. People can tell what Steve Martin is prescribing in any given month to any given set of people in any given location. That's a lot of information to work with. And I do think that the tracking mechanisms that are available currently can let DEA evaluate not only number of prescriptions, but also types of prescriptions and forms of buprenorphine that are prescribed. There are certainly cases where a monoproduct of buprenorphine is in somebody's interest, but I do understand the policy concern about that becoming a majority of prescriptions for any given provider.
So we had
Sorry.
this no, please. We had this conversation yesterday. DEA does not have access
Oh, I
to many
apologize.
instances
Yes.
to the PDMP. And
Yes.
so I think the way to ask you to expand is would you
I would, yes, I will. I would think that a national PMP makes more sense. And I had heard that comment yesterday, I believe. The fragmented approach right now is very difficult. If I have someone in Vermont, I have to press a separate box. If I have someone and I don't know what they're counting, Massachusetts looks at gabapentin, but others don't. Again, I think because that the relative downside is relatively low, but the upside is that DEA would essentially have a passive collection of information that wouldn't require another degree of surveillance. Thank you.
Could you expand on your perspective of audio only?
Yes.
And two-way?
Yes, audio only. Yes, so Boulder, my company, does not do audio only. For good reason, I think. We're in the new terrain. We're not really sure how this will be evaluated. But I've been advocating in Massachusetts on behalf of patients for what we have in Massachusetts, which now is law to compel the use of audio-only payments. The reason is very clear. Mass General came out with a study very early on in the pandemic showing that the people who are excluded from telehealth care are predictably brown and older people if video is required. There's no data to show that video is any more helpful in any part of medicine other than neurologic conditions such as Parkinsonism. The barrier to entry with video is so difficult, and highly technical people can't get me on video and vice versa, no matter how hard we try. And it seems to me, I'm hesitant, it's almost a fetish, this idea that video adds value. It doesn't. It often detracts, unfortunately, and it detracts for people who can least afford to lose care. I hope that helps.
It does. How do you evaluate that patient? Because you mean clearly this is a
Certainly.
very difficult. OUD is a very difficult thing to assess. So how do you assess that on the audio only?
No,
call?
certainly. In my experience, patients present to me the kind of patient that they think I'm looking for. And I try to dispel that as quickly as possible because I want to know who they are as a person. I don't think that's any different with video. I don't think that's any different in person and not with audio. If someone called me and said that they had a fentanyl disorder and they needed help, I would take that at face value. If someone wanted all the constraints and difficulties of getting buprenorphine and taking it, there are far easier things that they could do to in their lives. But I've been finding that these diagnoses are less difficult to make when someone calls and said, I overdosed and was in the ER yesterday. Can I get some help? And that hearing that over the phone would work just as well. Thank you. Thank you very much.
Okay. Commenter number 3.
Good afternoon. My name is Ujjwal Ramtekar, spelled as Ujjwal, last name Ramtekkar. I'm a double board certified psychiatrist. Administrator Milgram and Assistant Administrator Prosnak, I really thank you for holding these listening sessions, but as a psychiatrist, I would also say, thank you for very thoughtful commenting and very reflective, clarifying questions. It just shows your attention, your interest, and your enthusiasm in doing the right thing, so we appreciate that. I stand before you today as my role as the Vice President and Executive Medical Director for Quartet Health and Innovatel Telepsychiatry. We are a URAC-accredited behavioral health company committed to expanding access to high-quality mental health and substance use treatment for marginalized, underserved population across rural, urban, and frontier communities. We have been operating for almost a decade now, treating hundreds and thousands of patients across 31 states and Washington, D.C., across several settings, whether it's health systems, federally qualified health centers, community mental health centers, and more recently in their homes as well. For almost a decade, we have delivered this very vital mental health service to people struggling with all acuities, including serious mental illness and substance use disorders as well. I'm also the adjunct clinical professor of psychiatry at University of Missouri-Columbia and a consultant and faculty for several programs across the country that are geared towards building capacity in providing mental health access through primary care as well, ranging from statewide programs like Missouri Child Psychiatry Access Projects to learning collaboratives nationally like Project ECHO for primary care and mental health. It has been a great privilege, honestly, to look at the evolution in the 1.5 decade or so that I've been involved with telemedicine, particularly telemental health, and as being a part of American Academy of Child and Adolescent Psychiatry and American Psychiatric Association on their telepsychiatry committee, on the quality committee, developing some of the standards of care as to how to deliver high quality and safe telemental health and telepsychiatry for more than a decade. We have enough data that it definitely increases access, reduces no-shows, improves overall outcomes and quality of care as well when it's done appropriately within the standards of care, which are really already established for more than a decade there as well. I would like to share the Quartet Health's recommendations today in front of you for the special registration of prescribing controlled substances for the reasons of mental health treatment and substance use disorders. And let me also make a note that this has been the collective voice and expertise with 3 other national large telebehavioral health companies, Array Behavioral Health, Iris Telepsychiatry, and Psychiatry as well. In addition, we have been very fortunate for getting input, expert guidance from a lot of professional organizations like APA, ACAP, that represent thousands of clinicians across the country as well. So I thank you again for this listening session because it's not just about prescribing via telemedicine. It's also about equity. About 50 to 70% of patients across the country do not have access to a physical psychiatrist or child psychiatrist. I remember the days where I dreaded getting sick, because if I would be out of commission for a day, I had nowhere to place those young patients for about 9 months. When kids with autism who have to drive with their parents 4 hours in the heat while they're trying to save the gas money and therefore cannot put the air conditioner on, they're miserable when they cannot afford to find some accommodation or food for a 30-minute visit for a psychiatrist. That's miserable. And that is never a reflection of what is the true state of that child or that adult is from a mental health perspective. It really makes more sense to see them, evaluate them, and partner with them in what makes sense for effective and safe treatment in their own ecosystems. There are so many stories that we have heard around thousands of patients who would have not had any care at all if not for telemedicine. In the last 2.5 years, there were so many stories that we heard that they had a diagnosis, they had a treatment that they had to discontinue. And the only reason they were seeing me or my colleagues is because there was an option of telemedicine, which they were connecting through their local library's Wi-Fi with their permission, because they could not even afford that. We have had several stories of patients in frontier and underserved areas where their wait time was 3 to 6 months, and only because of telemedicine, it came down to 2 to 3 weeks. It really is an issue of equity, access, and public health. Unfortunately, last year we logged some of the highest numbers of suicides, about 50,000. And someone told me it's about 3,500 large plane crashes is what it is in 1 year. That's dark. Something is wrong, and we are really in mental health crisis. If we have blanket restrictions that also affect mental health access, then that will be really a problem for the society and for this country. So at the same time, we really understand and share the DEA's concern about potential diversion, and that's why we are going to put some of these recommendations for effective and safe prescribing of controlled substances, Schedule 2 through 5, via telemedicine. And this will be for legitimate, appropriate prescriptions through telemedicine without any in-person care when it's appropriate. Telehealth in general, in our general framework, is not inferior than in-person care. Telehealth is not necessarily just a modality, it's a setting in which we deliver care. And sometimes that setting is not appropriate. And that is totally up to the clinician and patient's judgment about that setting being right or not, and referral to any in-person care needed. Just as we do not force somebody who needs inpatient treatment to be treated in an outpatient setting, there is no clinician who would say, you need in-person care or higher level of care, but we still are going to treat you with telemedicine. That just does not happen. That is not the standard of care. So as the general framework, we would recommend that DEA implement a special registration for telemedicine for the short term until the agency is satisfied with the longitudinal data of safety and impact on potential diversion of these medications. And we hope it will go away in a few years, like the ex-waivers did. It will be a new registration that would allow a provider to prescribe controlled substances via telemedicine in absence of in-person evaluation or referral, and this would be separate than the existing general statewide DEA registration. However, we recommend that the agency allows the clinicians to have one single national special registration so that the clinicians are not required to have registration in each state as long as they have one statewide regular DEA registration, or they don't need to have any physical location to store and dispense the medications either, because all of this is happening through telemedicine. Well, in response to the agency's questions for guardrails, we definitely do have some specific recommendations for the safeguards. And again, these are based on already established clinical standards that we do no matter whether we are delivering care in telemedicine or in person. We would schedule the prescribing through the special registration without in-person care in telemedicine to Schedule 2 and non-narcotics 3, 4, and 5. We may require providers to evaluate their patients at least once every 90 days, but should be, again, left to the clinician's discretion around the stability and the safety of the patient. It could be more. But generally, for a controlled substance treatment, we could suggest a 90-day restriction for timing. We can require the providers the capability to furnish a fully HIPAA-compliant audio-video synchronous visits as well. Now, this would be really important probably in our mental health treatments for the initial visits, but it certainly is a burden for a lot of people who may not have access to technology or the other means to make that happen. So follow-up cares, again, could be with audio. But again, it should be at the discretion of the clinician who wants to assess more or want to look for some other signs that requires video. That probably should be left to the discretion of clinician for any follow-up visits. The initial visit, although, could be required for audio and video. We should be prohibiting from requiring, recommending, or referring to a specific pharmacy or pharmacy chain, unless it comes up from the patient, because there may be only one pharmacy in their town, and that's their option. So that's reasonable. We would like to suggest excluding ketamine from the list of medications that can be prescribed under special registration, because again, per standard of care, it requires about 4 hours of in-person observation with a physician on site. We should be authorizing prescribing medications, but not necessarily storage or dispensing of the medications as well as a part of this safeguard. And then limiting the prescribing of Schedule II and non-narcotic medications like stimulants for the treatment of mental health conditions by a physician. That includes primary care providers, because now it has become a competency through their training and their professional organizations to appropriately train them in that, or with advanced practice nurse practitioners or physician assistants who have a certified qualification in psychiatry as well. We know that a lot of prescribing happens outside of these specialties, and that's purely a reflection on access, demand, and supply, and that's really much needed thing. But if we were to do it safely, we would recommend that anybody who does not have these certifications as an APRN or a PA, we recommend a one-time 8-hour training requirement by an approved state medical board on prescribing controlled substances, not necessarily about particular condition. We obviously cannot manage what we cannot measure. So in response to the DEA's request for additional safeguards, we could propose placing a limit on the number of prescriptions per provider per month. Again, this would be totally based on what would be an average full-time provider who sees patients in an ambulatory setting with a mix of emergency room consultations and occasionally probably covering for their physician colleagues who work in the same practice as a bridge prescription. And we could also suggest potential data reporting, but with the caveat that the resource-constrained not-for-profit organizations and the providers practicing there be exempt from that as well. So from the number perspective, we would suggest possibly 500 controlled substance prescriptions per provider per month. But in specific circumstances, if the provider exceeds that because it is truly their specialty or it's really the specialty population they're treating, that we provide them with an opportunity to write a statement of justification for exceeding that one rather than automatically red flagging it, because that might provide us insights into some legitimate reasons as to why that happened. Second, we suggest the providers to maintain data and if required, provide the data in non-PHI format, and that would include things like DEA registration number, the healthcare entity, the name of the medication, the possibly NDC number of the medication, the number of prescriptions written, and the date of the prescription. Now, I would also mention here that these are the data elements that could be automated and appropriately stored in the electronic medical records without any specific intervention from the provider, because it's already a huge administrative burden for the providers, who often, myself included, do not get time to eat lunch. We're doing charting or often working in the evenings just to complete the charts. On top of that, if you are given this administrative burden, it would be difficult for sure, and it might inadvertently reduce access because then providers don't want to engage in that at all. However, we definitely recognize the need for measurement and data. As some of the previous speakers have already said, and I would echo, that the only prescription that is at risk of diversion is the prescription that is filled. And so the real source of truth for that kind of information is the pharmacy data. We also have PDMPs, but we understand that either DEA does not have access to that data, or there's a variability between states about how that is managed and run, and there's not really a national system. So this would be a wonderful opportunity for DEA to lobby for creating a national database similar to NPDB to support and access any of those data as well. We have over 2 decades of evidence that high-quality mental health services can be safely delivered through telemedicine in accordance to standard of care. And so imposing an in-person requirement for patients seeking these mental health treatment will certainly impede access to psychiatric care and worsen the crisis. On behalf of Quartet Health and our partners, I want to thank you for your consideration for our recommendations for the special registration and what we believe to be a good collaborative path forward that will allow DEA to maintain some important controls on diversion, but will also ensure that practitioners can continue to furnish a very high quality and safe mental health to the patients when they need it, how they need it, and where they need it. Thank you for that thing and appreciate it.
Can I ask a few follow-up questions?
Yes, please.
Thank you so much. I just didn't hear this clearly. You said DEA could lobby for the creation of a national database and then you had a bunch of initials. I apologize, I missed that.
Oh, like the state PMP programs.
PMP.
Correct.
Okay. When you talked about a potential guardrail of requiring an evaluation of a patient every 90 days, I assumed you were talking virtually.
Correct.
Okay, just wanted
Correct.
to make sure. Thank you. And could you just expand a little bit on ketamine and why you think that should be excluded? And also, are there other things like ketamine that you would have similar concerns over?
Correct. So the rationale for that statement is that it's still a newer treatment. It is a very effective treatment, but we still are looking for more and more safety data, and currently there's a requirement of observation in person with a physician on site. If the physician is on site, then there's probably no reason to prescribe it virtually either, because we are really observing them. And so there could be other potential newer treatments that are still not fully tested in masses and has not really become a standard of care. That could include some of the psychedelics, for example, as well. I'm not saying that it may not change. That's the good thing about science and evidence-based, that it changes, and as it evolves, we evolve our standards of care and safety protocols as well. Okay. Thank you so much.
Okay, and I see commenter number 4 coming to the stage now. I'm going to take a 5-minute break at the conclusion of her remarks, just for us to stretch legs and get out and use the facilities if anyone needs to do so. So I welcome commenter number 4 to the stage.
Thank you. Of course, thank you. My name is Krista Natoli, CHRISTA I'm the Executive Director of CTEL, the Center for Telehealth and eHealth Law. We're a 501c3 nonprofit telehealth research institute focused on policies and regulations that impact the delivery of virtual care. We are bipartisan and not beholden to any particular stakeholder. I would like to express the deep gratitude of CTEL for the opportunity to provide comments today concerning the crucial role played by the DEA in the prescribing of controlled substances via telehealth. CTEL stands alongside the DEA in its commitment to safeguarding our communities from drug abuse, diversion,
while supporting policies that promote quality medical care and legitimate patient access. As a research institute, we aim to present evidence supporting the long-term viability of the DEA flexibilities implemented during the COVID-19 public health emergency waivers. Dr. Yael Harris and her team have collaborated with CTEL as impartial third-party researchers. In these remarks, we will present data that reinforces the ongoing use of telehealth for prescribing life-saving treatments. It's my pleasure to introduce my co-speaker, Dr. Yael Harris, the CEO of Laurel Health Advisors. Dr. Harris has been an invaluable independent researcher for CTEL, gathering and analyzing data from across the United States to evaluate the effects of telehealth.
Thank you, Krista, and thanks for this opportunity. My name is Yael Harris. That's YAELHARRIS. I am the CEO of Laurel Health Advisors, which is a health services research company focused on using data to drive health equity and access. As a health services researcher, I have over 25 years of experience, half of that with the federal government Department of Health and Human Services. As a researcher, I love data. So I always look at what the evidence shows me before I endeavor into doing any new research. So according to the Journal of Drug and Alcohol Dependence, before the pandemic, in most instances, diversion was associated with a real need for treatment among those unable to access a provider or obtain medication. This is a really important finding. Even though there was illegal diversion taking place, the root cause was access, not abuse or misuse. With the implementation of the DEA's public health emergency waiver, data reported by the American Psychiatric Association provides substantial evidence that the expanded use of telehealth, despite unprecedented growth in telehealth use, did not lead to an increase in diversion. According to data from NIFLS, the National Forensic Laboratory Information Systems, during the pandemic, there was a decrease in buprenorphine diversion. A March 2023 study in the Journal of American Medical Association Psychiatry confirmed that the increase in telehealth provision of medications for opioid use disorder was associated with a reduced risk for fatal overdoses. Research studies in peer-reviewed journals, including the Journal of Addiction Medicine, Journal of Substance Use and Treatment, and the Journal of the American Academy of Child and Adolescent Psychiatry, have evidence that the ability to initiate and renew prescriptions for controlled substances via telehealth increased access to critical vulnerable populations, which include children and young adults struggling to focus and succeed in schools, families of whom are on maybe low income, rural, and lacking public transportation, which would make it difficult and devastating to take a day of leave from work to get their child care. Pain management for individuals unable to leave their home and seek treatment, and access to medication-assisted treatment, or MAT, for individuals living with a substance use disorder. Also, access to medically necessary Schedule IV anxiolytics for individuals living with some serious mental illness. The research presented by the Journal of Substance Abuse Treatment points to the fact that in the absence of telehealth, we would have seen lower levels of compliance for substance use disorder. According to the National Council for Wellbeing, many individuals experience long wait times to get into insurance-covered programs for behavioral health, even those that live in areas where there is a psychiatrist. Access to in-person medical care is a privilege that many Americans with socioeconomic disadvantages or experiencing mental and physical disabilities do not have. According to the Commonwealth Fund, as of March 2023, 160 million Americans live in areas with behavioral health professional shortages, with over 8,000 more professionals needed to ensure an adequate supply. CTEL's research has shown that at the state level, all states accept telehealth to establish the patient-provider relationship. And according to recent data collected by the National Council for Mental Wellbeing, the national average wait time for behavioral health services is 48 days. That's nearly 7 weeks. Among those seeking treatment for substance use disorder, this wait is untenable. If you ask a substance use specialist, they will tell you that when a person is living with a substance use disorder is ready for treatment, even a 24-hour wait may be too much. Without the benefit of being able to promptly prescribe buprenorphine to this at-risk population, many individuals who may have benefited from MAT therapies will go without. According to the South Dakota Department of Social Services, limited access to MAT is associated with a reduction in relapse and overdose, and greater access is associated with reduces the risk of criminal activity and transmission of infectious diseases. Data from the American Academy of Pediatrics shows significant persistent shortages. Wait times for pediatric subspecialists often exceed 2 weeks, and according to the Children's Hospital Association, families wait an average of almost 15 weeks to see a developmental behavioral pediatrician. As a mother of children with ADHD, I know firsthand the importance of timely diagnosis and treatment. While my children were struggling in school, many pediatric psychiatrists were not taking new patients. As any parent knows, weeks can mean the difference between academic success and failure for your child, affecting their self-esteem, their confidence, and their mental health. And I was fortunate. According to the Centers for Disease Control and Prevention, less than half of children with ADHD even receive treatment. Enabling patients to see providers virtually, as well as receive prescription medications virtually, is a critical component for improving our healthcare system. Research published in the Journal of Substance Abuse Prevention and Policy demonstrated that the impact of how increased enforcement to avoid harm associated with controlling substances has actually led to fear and unintended consequences. These include higher rates of diversion of opioid agonists, greater fear of disciplinary action against opioid prescribers, resulting in forced tapering and underprescribing, and providers refusing to take on patients who legitimately require opioids. The Controlled Substances Act proposed establishing a special registration process with the key objective of increasing access to needed medications safely. The rationale provided for this registry was to prevent illegal prescribing and potential harms associated with diversion and inappropriate use. As I mentioned by my peers earlier today, less access is actually associated with more misuse. Let me turn it back to my colleague, Trista.
CTEL is in support of any policy change that will eliminate unnecessary administrative burden on prescribers while improving access to quality healthcare interactions and curtailing illegal diversion activities. These changes may include the use of existing electronic data sources, including the prescription drug monitoring programs in every state, or creating a national program. Use of pharmacy data to track and red flag certain prescribing activity, and enhanced use of electronic health records to evaluate and end improper prescribing activity, as well as incentivizing legitimate prescribers to flag inappropriate conduct. We understand DEA is seeking input on potential guardrails and safeguards. Those that already exist include medical exam requirements. It is already necessary that the standard of care be met for medical examination and evaluation. High quality of care does not require proximity. Physical examination does not always happen with in-person treatment either. It's a standard of medical care independent of the virtual issue. This is a process independent of whether the exam is done via telehealth, in person, or from collateral sources. Number 2, identity verification. The in-person advantages of identity verification, vitals, verified in-person drug screens do not need to be completed by a DEA-registered provider and can be done by another team member, such as a nurse, medical assistant, therapist, or case manager, in conjunction with a licensed medical provider, either in a brick and mortar or in-home. They can also be done via biometrics or in a facility at a point of entry where no DEA-registered provider is in the building. And finally, number 3, prohibiting prescribing based solely on a medical questionnaire. While diversion was an issue even before the widespread use of telehealth, limiting access to prescription medications via telehealth is not going to solve the issue of diversion, but may in fact exacerbate it. By limiting legitimate prescribing encounters while failing to root out those diversion activities that have persisted for years. Experience shows any new burdens are likely to lead to great public health and safety concerns when patients aren't able to access needed medications in a timely manner. As patients and prescribers alike have gotten accustomed to the regulatory flexibilities implemented as part of the COVID-19 public health emergency waivers, our data shows that diversion activity has not necessarily increased. Therefore, restricting these flexibilities is an unnecessary step that will impact patient care while not preventing problems DEA has identified. To recap, CTEL supports the continuation and permanency of telehealth flexibilities made available during the public health emergency waiver, the creation of the special registration, and guardrails to protect against inappropriate prescribing while increasing access to life-saving care. On behalf of CTEL and the telehealth community, we appreciate your attention to these important matters. Thank you.
Just to see if we have any follow-up questions.
Okay.
No, thank you. Okay. Thank you both. Thank you. Okay, I see that it is now 1:38. We'll just take a 5-minute leg stretch or use of the facilities. Thank you.
This is the DEA Telemedicine listening session. We're currently on a break. Thank you for joining us. This is the DEA Telemedicine listening session. Thank you for joining us. We're currently on a break.
that short break. I am now pleased to call up commenter number 5 to the podium for his remarks. All right, thank you.
Thank you.
Don't forget to say your.
Yeah, I've got it all written down here. So, hello, I'm John Wells, JohnWells, and I'll forego, the typical academics list of, various accreditations and things like that. I'll just say I'm an associate professor of clinical psychiatry at LSU HSC, so Louisiana State University Health Sciences Center in New Orleans, where, at least in part, I specialize in providing integrated mental and behavioral health care to remote and rural federally qualified healthcare centers, which we'll call FQHCs, as well as training residents to do so. Now in Louisiana, we have quite a few very rural and remote populations. I have no financial conflict of interest to report. Really, I'm primarily a clinician and a teacher. The focus of my comments today really are to advocate, irrespective of the other concerns which have been spoken about already in terms of specifics around buprenorphine prescribing, things like that, stimulants for children. The focus of my comments today is really to advocate for special rules in regard to FQHCs and primary care clinics under that aegis, so the lookalikes as well. These clinics provide longitudinal and often really intergenerational patient care, and I've been really fortunate to be able to immerse myself into some very well-functioning FQHCs and see maybe a vision of what things could be, or maybe it's only nostalgia for what things used to be, and things are really moving in a different direction. Clinicians in these settings, they really know their patients very well. They know their patients' families and neighbors. They know their livelihoods, and these clinicians really share the unique economic and geographical challenges of those patient populations in these FQs. Our patients generally like to attend clinic in person. That's not always universally the case. But at times in their lives, they experience limitations on their ability to do so. Hence, telemedicine has been such a valuable sort of additive tool in general. For a variety of reasons, these remote and rural communities have been profoundly affected by, Schedule 2 to 5 controlled substance diversion, overprescribing and misprescribing, and in particular, benzodiazepines and stimulants are particular areas of concern, for our teams, which is why I'm a little bit hesitant to see things opened up too much. And so in that sense, perhaps this is a bit of a cautionary note. One of the most difficult tasks that we, are faced with embedded in these really rural and remote communities is what I call deprescribing, and certainly I'm not the one who coined that notion. But especially when our patients have been able to access remote providers who are not invested in their community, we are kind of left to mop up the mess that's caused. And this is not unique to telemedicine. It certainly existed before telemedicine. People would drive to Texas and go get medications in places where they knew they could access them. But telemedicine prescribing of controlled substances certainly made it a lot easier. So benzodiazepines, opiate narcotics, right, stimulants, and now cannabis, where these patients are really getting the prescriptions remote geographically and culturally from, the place where their primary care is housed and where they live. I know as a country we're facing a crisis in primary care, and we've struggled to really incentivize clinicians to work in these areas. It's one of the reasons why I bring the residents out with me to try to get them interested. On the other hand, many of the providers who end up, physically practicing in these places came from these places and really have a vested interest in maintaining the strength of those and the health of those communities that they're from. They know these populations better than anyone else can, and really share in the joys and losses and pains of these communities that they serve. So there certainly is a problem recruiting people, but when it works, it does work well. So during the pandemic, telemedicine exploded, as we all know, for a variety of reasons. Telemedicine had before the pandemic and still retains a critical role really as a tool, for the provision of primary care in these communities. But the community providers in these FQs certainly expressed to me that they are worried about kind of a free-for-all of remote providers. It takes away their business, makes their clinic less resilient, and then, like I'd said, then we are often left with mopping up prescribing that has not been so clean when provided by providers who are not embedded in these communities. Our patients, just to paint a little bit of a closer picture to home of where I work, they're fishers, they're offshore operators, boat operators. They really don't often have access to the same sorts of time scales that we've talked about. Like a month is a very arbitrary thing for somebody who works offshore for weeks at a time or has to travel, many, many miles to find work and may be there for several months, or, who has to fish every hour of every day, during, say, the shrimping season. And so, for that reason, telehealth has really been, as I'd said, a critical tool to help these primary care clinics maintain, their ability to really treat their patients in the best possible way. These clinics are really trusted. And so, I do think that that providing mechanisms for scheduled substances to be prescribed by telemedicine should be expanded and essentially made frictionless in a lot of ways. I also do think that that there are some problems with it being opened up sort of willy-nilly, and that's why I like the idea, at least in my own mind, of utilizing systems that are already in place, like the FQHC system, to help ensure that that diversion, misprescribing, safe prescribing are able to be monitored. So in this context, I guess I put together some specific recommendations. I think that many of the people who came before me, have sort of more sophisticated ideas and better understandings of what the national sort of, what the push is for national providers and large-scale providers. We've talked a lot about the PMP. There are problems with the PMP, and I'm in complete agreement with everyone else who has spoken about that as a resource, really one that should be, expanded to be a national database. We often find problems with reporting from pharmacies and things like that, and presumably, and also different types of medications which are not listed in certain states. So those things have all been mentioned. In the FQHC setting, in particular, we like inpatient, in-person visits, and we really like to, know our patients, and so, it wouldn't be remiss from my perspective to have, some controls around whether or not people should be seen in person at least at some point early in their course of, being prescribed a controlled substance, whether that's before they are seen in person or whether maybe it's shortly after they're seen in person. But I really do, I guess what I would mostly push for is that I think that, as people had pointed out before me, there are very few bad actors when we're talking about primary care doctors and community psychiatrists. And so really allowing a lot of discretion in terms of what's the interval at which a patient needs to be seen in person, should be allowed and should be just documented within the clinical reasoning, which presumably physicians are already, doing. And that would include also, the in-clinic toxicology testing and screening, again, at the prescriber's discretion, because in this FQHC context, right, we really are concerned about, sort of a panel of patients who live nearby us. And then, finally, I guess, as I alluded to earlier, the restrictions on the, on the length of time, 30-day supply, that sort of thing, can be very onerous, especially, in addition, in my patient population, we have a lot of people worried about hurricanes and things where at a moment's notice they might be required to evacuate immediately. And so a 30-day, supply of controlled substances, the inability to, reach your doctor or to have them be able to send, a stimulant across state lines sometimes can be very problematic. So I understand I'm not, giving really clear guidelines. I just wanted to point out some issues that I thought maybe hadn't been brought up. Thank you for the time.
Can I ask? Trying to articulate this in your words a little bit. You talked about tox screens, how often patients should be seen, whether there's times, there should be a time limit, and I would just ask you to expand a little bit on a sort of, I think, related question, which is when we start talking and also talking about deference to physicians and prescribers. When we start talking about standards of care, when it comes to prescribing some of the medicines you talked about, should there be specific standards of care related to telehealth prescribing? And so, if you're, I may not be articulating this well, if you have someone coming into your office, you're doing a tox screen on a certain basis. If someone's virtual, would you have that be the same timing or different time? Would that change how you would see the standard of care if it's a video relationship?
Well, I think that, thank you for asking that. I think that my perspective, at least the one that I'm illustrating today, is somewhat different because I'm not sort of advocating for a national, group that would provide it really across state lines, but really the health of community clinics. And so to answer your question, all of the primary care doctors that I work with, all the psychiatrists and other people that we have embedded in these clinics, they know their patients. And so really telehealth for us, whether it's telephony, whether it's with video, whether it's in person, it's a continuity of care across usually multiple generations. And so, that's a little bit of an artificial question because it's no different to me if I've seen a patient for the past 20 years and I have to talk to them on the phone and they're going to be gone, right? I mean, I feel comfortable. But if they go to somebody who they just contact at 12 o'clock at night because they feel anxious and that person is 3 states over, I think that's a different situation. So I'm really advocating for this community health clinic.
Actually, that's the last point that you just made is what I'd like to ask you to expand on is how do you see dealing with that issue of that the patient three states away getting it, and now you have to mop it up, as you called it. Like, I mean, I'm sure you've had these discussions, so I'm just trying to pick your brain on what those discussions were on.
Yeah, I mean, it's a larger problem than I can certainly deal. I mean, I deal with it at a granular level, so that's why I really I hesitate to advocate for just a sort of an opening up of prescribing to for. And in my world, really, it's less. So I'm not talking about treatment for substance use disorders so much as benzodiazepine and stimulant prescribing, okay, which are hugely problematic in these remote and rural settings. And so, I spend a lot of time really saying to people, you don't need to be on, 6 milligrams of Xanax a day that other good doctor gave you, right? Of course, you're seeing me, not that good doctor anymore, for whatever reason, whether they've been, I mean, there's a whole myriad of reasons why they no longer would be seeing them. So I don't know if that quite answers your question, but that's, that's sort of the concern on the ground in community clinics, I think.
Okay, we'll now invite commenter number 6.
Okay, good afternoon. I am Dr. Juan Incapie Castillo, spelled Juan, last name Hincapie-Castillo. I am an assistant professor of epidemiology. I'm here representing the National Pain Advocacy Center, or NPAC. As a researcher, I'm at the intersection of pharmacoepidemiology, and injury prevention. I leverage real-world data to evaluate and promote evidence-based policymaking, and my primary focus is on improving prescribing policies and the provision of equitable pain management. Like I mentioned, I'm here today on behalf of the National Pain Advocacy Center, or NPAC, where I currently serve as president of the board of directors. NPAC is a nonprofit organization that takes no industry funding and advocates for the health and human rights of people living with pain. This means that I'm here today representing the 50 million Americans who live with chronic pain, the 17 to 20 million Americans with persistent pain so severe that it regularly prevents them from participating in life activities and work, and millions more with acute or episodic pain. Chronic pain is the chief cause of long-term disability in the United States, and pain frequently accompanies other disabling conditions. The explosion of telemedicine amid shutdowns related to the COVID-19 pandemic and the related PHE proved transformative for countless patients with pain and disability who were otherwise unable to access care. For these vulnerable patients, telemedicine extended a needed bridge to critical care, one that the DEA must not now resign. Regarding the prescribing of Schedule II substances for pain, NPAC is chiefly concerned with the continuity of care for patients with long-term pain who currently take opioids. Today, these patients face substantial barriers to care that pose an imminent risk to their health and lives. As public health agencies from the CDC to the FDA have acknowledged, many such barriers stem from government actions like those the DEA considers today. 2 studies by Lagisetti and colleagues published in the journals of JAMA Network Open in 2019 and Pain in 2021, for example, found that upwards of 40% of primary care doctors will refuse to treat a new patient who uses opioids to manage pain. An NBC News piece recently highlighted the plight of a patient who called 150 different providers, desperately trying to arrange care. Disruptions in care are deadly. Many studies show that opioid disruption places patients at increased risk, including a 3 to 5-fold increased risk of overdose and suicide. Studied by Glantz in JAMA Network Open in 2019, James in the Journal of General Internal Medicine in 2019, Oliva in BMJ in 2020, Agnoli in JAMA 2021, Fenton in JAMA Network Open in 2022, and La Rochelle in JAMA Network Open also in 2022, all found a heightened risk for death, overdose, and/or suicide with opioid disruptions. Even the stabilization of dosage carries risk that continues for up to 2 years after dose is destabilized, according to the study I mentioned by Fenton and colleagues in 2022. Opioid disruptions are associated with other risks as well, including the increased need for emergency medical care and hospitalization, according to Mark and colleagues in the Journal of Substance Abuse Treatment in 2019, and Magnam and colleagues in the JAMA Network Open 2023. This life-threatening and health-destabilizing problem affects a substantial number of people. As many as 8 million Americans use opioids to manage pain long-term, more than 3 times the number with a diagnosed use disorder. The DEA has seen the effects of patient abandonment and opioid disruptions firsthand. When the DEA suspended a doctor's license in California, for example, 3 people died, 2 of them by suicide. Another, a wheelchair user with dystonia, was able to prevent withdrawal by using a methadone clinic, but the medication did not manage her medical condition. She suffered persistent spasticity that continuously knocked her out of her wheelchair for several months until she was able to arrange alternative care that required her to travel to another state in that condition. The threat to life is not limited to overdose or suicide. Kenny Mestas, for example, a quadriplegic living in Colorado who recently testified in the Colorado legislature, had a heart attack and woke up on a ventilator after an opioid disruption. At a moment when the street supply is especially dangerous, when the CDC is warning especially about deaths from counterfeit pills, and when overdose deaths continue to escalate, surpassing 107,000 in 2021, making policy decisions to roll back a proven avenue for care and one that put people in harm's way is reckless. In order to protect continuity of care for this population, our suggestion in alignment with the questions asked in the DEA framework is as follows. The DEA should allow telemedicine prescribing for continuity of care in these patients by permitting an established opioid dose from a previous in-person prescriber to be continued using telemedicine. This approach is analogous to guest dosing permitted by SAMHSA in an opioid treatment program, or OTP, and is similarly protective of treatment continuity. This is the preferred action and will leave in place existing avenues for care for this population. Alternatively, the DEA could allow 60 to 90-day initiation via telehealth by a new provider with appropriate documentation that accords with relevant state medical board rules and procedures. The DEA should also consider allowing a 60-day initiation via telehealth even for new prescriptions via telemedicine for pain in situations when people cannot otherwise physically access care. Often, a physical examination will precede Schedule II prescribing for a new opioid prescription, but care deserts in the United States are vast, and in-person care is a poor proxy for a bona fide healthcare relationship. According to the Health Resources and Services Administration, nearly 100 million Americans live in areas with a shortage of health professionals. Rural areas where many clinics and hospitals have shut down are especially burdened. A 2022 systematic review on the barriers to access to pain care for older adults in rural areas conducted by Sonte and colleagues and published in the American Journal of Palliative Care, for example, identified transportation-related issues as a major access barrier to pain and palliative care, precisely the type of barrier mitigated by telemedicine. All impediments to care and continuity of care are likely to be borne disproportionately by people with disabilities, racialized populations, and people living in rural areas or other healthcare deserts. Disparities in pain experience, biases in pain assessment, and inequities in prescribing for pain based on race, gender identity, and disability are all well documented. In regards to prescribing for Schedules 3 to 5, the timeframes proposed by the DEA for Schedules 3 to 5 medications are out of sync with the realities of the U.S. healthcare system. According to a large survey of wait times for doctor's appointments in the 15 largest metropolitan areas conducted by AMN Healthcare, for example, found that the average wait times to arrange primary care was 26 days, with some cities reporting 45 days. For rural areas or specialist care, the wait times are longer. The DEA should extend telemedicine to prescribing all controlled substances in areas where patients lack realistic access to in-person providers. Doing so would likely require DEA to abandon existing geographic limitations, which reflect an anachronistic pre-telemedicine world. These considerations are extremely important considering the continued increase in drug-related overdoses in the country. patients living with opioid use disorder also need to have access to life-saving medications that can be prescribed by telemedicine. Now, regarding the government's interest in protecting against diversion and the evidence of success of telemedicine prescribing amid COVID-19. Importantly, the flexibilities that allowed for telehealth prescribing during the PHE do not appear to have resulted in documented harm. A rise in prescription-related drug overdose deaths is not evident in provisional data from the National Centers for Health Statistics. On the contrary, studies that have examined the impact of telehealth prescribing during the PHE found, not surprisingly, that telemedicine prescribing reduced overdose mortality. Notably, 3 major studies focused on buprenorphine prescribing via telemedicine showed, including a major study in which the lead author was Christopher Jones, the former director of the National Center for Injury Prevention and Control at CDC and current director of the Center for Substance Abuse Prevention at SAMHSA, that telehealth prescribing reduced overdoses, providing a literal lifeline to patients who experience lapses in and barriers to care. Finally, with regards to the additional question DEA asked in its framework about appropriate guardrails, should the agency extend teleprescribing of controlled medications? The best solution is for prescription drug monitoring programs to be modified to include the mode by which the dispensed medication was prescribed to identify telemedicine prescriptions. Nevertheless, any such modifications should be accompanied by an explicit avowal from the DEA that telemedicine prescriptions are not inherently inferior, nor suspect to avoid their being denied by pharmacy chains, something that we saw happening during the pandemic by major chains in buprenorphine dispensing. A separate record-keeping system for providers is not a good idea. It raises cost, burden, and security concerns. A duplicative system increases risk of error that may ultimately endanger patient safety. Thank you for your time and for your consideration.
And we're calling commenter number 7.
Absolutely. Hello, everyone. My name is Dr. James Uliger, James Ulager. I'm affiliated, I'm the medical director for a company called Pursue Care that provides addiction treatment primarily but not exclusively by telehealth. And while I'm certainly here on Pursue Care's behalf, I'm also first, as a physician, I always think of myself as a human first, a physician second, and then my affiliation third. And as such, my mission in life is not to sit here and defend telehealth as an ideology. My very mission in life is to make sure the patients that I take care of every day don't end up on the fentanyl board that's out here, because that made me really sad. Every time I go, it's hard to go to the bathroom here because you have to walk right by that. So that is my purpose, and telehealth is the tool. I want to lend a little bit of I would have never in a million years thought when I started a career in medicine that I would be, number 1, practicing addiction medicine, and number 2, doing it by telehealth. And I went through a bit of a conversion, and I want to, in 2 minutes or less, give you insight into that and really what happens when we're treating a patient with an addiction disorder with buprenorphine. And that's really important. Buprenorphine is life-saving medicine. A meta-analysis of 500,000 patients published in 2019 found people were 8 times less likely to overdose if they were in an MAT program. That could be buprenorphine, naltrexone, or methadone, but those latter two have their own challenges. So 8 times, and compared to other chronic diseases, and part of my agenda is to help people understand that the opiate use disorder is a chronic disease of the brain as defined by the American Society of Addiction Medicine. Just like asthma is a chronic disease of the lung, or heart failure is a chronic disease of the heart. This is the same thing. We do not have other pharmacologic treatments in chronic care that reduce the risk of death by 8-fold. If we can get to a twofold reduction in mortality, that is hitting it out of the park. The fact that we have a medicine that can decrease overdose death by 8-fold is astounding. It's astounding, and it's so amazing that it starts to become concerning to me, not that we're, rather than asking what safeguards we put around it, and safeguards are important, and I'll get to that in a moment, but how do we get this to everyone? It's also life-saving medicine because you need to know when you sit across from a patient, whether it's on telehealth or in a room, and I've done both, and you watch them coming in ready to detox off fentanyl, and you watch the transformation that they undergo physiologically, emotionally, socially, in 72 hours, and I'm generalizing, but you can see it. In 72 hours, their hair is combed, their teeth are brushed, they're wearing clean clothes. In 4 weeks from then, they have a job. 3 months from then, they have their kids back. That is why it's life-saving medicine. And I think most of us know this, but this is so important to start at there's still this perception that people who are using buprenorphine are still getting high. Most people I've seen who by the time they come to me, they haven't been high in years. They're just trying to feel normal. And they can't go to work if they don't feel normal. And they can't take care of their kids if they don't feel normal. The problem is buprenorphine is not available. In December, there was a publication that 13% of Americans with OUD get treatment, and it's worse in rural areas. That makes it sound like we're a developing country who doesn't have the resources in place to take care of the chronic needs of its patients. And the reason it sounds that way is because that's true. We don't have the resources in place we need to give people access to this life-saving medicine. Why is it worse in rural areas? A lot of my patients don't have cars. They can't afford cars. They live at the end of the dirt road in eastern Kentucky. If they did have a car, they couldn't drive it because they lost their driver's license. I see many patients with one pharmacy and maybe one doctor's office in their town, and I love the FQHC. Whoever was, my heart is very much, I was a rural family doctor for over 10 years before I started doing this on telehealth. Again, a big change in my life. But a lot of them don't want to or can't go to those places because they may have burned bridges or they may be too ashamed of what they're facing. Other reasons for access, people have to go to work. So when we're seeing somebody in a buprenorphine program, we're seeing you a lot. At first we see you weekly, sometimes even more. And then after 3 or 6 months, we might go to monthly, but we're never seeing you less than monthly. My patients tell me, like, my boss wants to know where I go every second Tuesday of the month. And, you know, having been an in-office primary care doctor in a small town for a long time, you could not get into and out of my office in less than 2 hours, I promise you. And I wish that were true, or different rather. I wish it were different, but it wasn't. And so it was a half-day affair for people who are trying to get their kids back, stay at work, keep a job. And then it got worse because we want to monitor patient safety, and when people aren't doing as well, you see them more often. So then that person whose boss wants to, I say, you know, if this is a real conversation, look, my friend, I see I've looked at your drug screen, I'm concerned about what's going on, I'm just going to give you a week's worth of medicine. Doc, I can't do a week, I'm going to get fired. I'm going to get fired. And we could talk as much as we want about protecting, you know, with an ADA or protecting employment, but it still happens. So people need to go to work. And then we just don't have providers in rural areas. So most of the care I provide is in rural areas, and our company provides in rural areas. There are no providers. Part of the reason I left my rural community in Vermont, where I still live, by the way, but I still practice there, is, and I would never say that Vermont has it all figured out because we don't, but I knew there was a place in the country that needed the resource more. And I'm not going to live in eastern Kentucky and West Virginia right now, but that's where the epidemic of overdoses is worst and the need is greatest. And I love seeing my patients in eastern Kentucky. People have been talking about personal relationships. I have very personal relationships with my patients over telehealth. I see them, most of them, way more often than I ever saw any of my primary care patients. And that's very important. So telehealth is a very important part of the solution, but it needs to be safe. I have a number of nurse practitioners I work with, and we talk a lot, and they ask, say, you know, Dr. Jim, what's the how are we going to keep our patients safe? And I'm going to say, we're going to do all of the same things that we do in a face-to-face clinic, we're going to do on telehealth. If you're worried about somebody, you see them more. You check the PDMP before every prescription. You check their toxicology. We have developed some unique ways of improving toxicology and getting toxicology. I would say we haven't developed them. We're working with people who have developed them. We're developing the incorporation, would be a more adequate way of saying it. So that's, we're doing all the same things. And in fact, some of those things are easier to perform by telehealth than they are when somebody's face-to-face in my clinic. You could put on a good face when you come to my clinic. When you're at home, I see what's going on at home. I found people in domestic violence situations. I've realized that people are homeless. When they come to your clinic, you don't always find out that they're homeless. When you see where they're calling you from, you know they're homeless. And that's all what contributes to what we might call an aberrant thing. You know, not all aberrancy is diversion, but it is always a cry for help. And you can see that so clearly. And my patients who are trying to keep their jobs, they log in with me on their lunch break from their car during a 10-minute coffee break. Doc, I'd be happy to see you. We have providers who see people into the night because we don't have to staff a clinic. We have people who work second, third shift. I need to see you at 9 o'clock. No problem. We do that. So what about the numbers? And the numbers are important. It's important that we not think about, I've heard people talk about telehealth as something scary or whatnot. Let's look at the outcome. And somebody else, I think it was Dr. Martin shared, forgive me if it was somebody else, it was a retention data. And retention is a great surrogate marker for success, not a perfect one, but a very good one. Our 90-day retention is 85%, which is not quite twice the national average for brick and mortar clinics. And I think there's many reasons that that's true. And by the way, not all retention is good. We certainly look for people who, you know what, maybe this person isn't the right person for telehealth. I will also say I've stretched my notion of what is appropriate for telehealth, not because I'm devoted to telehealth, because I'm looking at the alternative. So when people are advocating for in-person care, the alternative is often not, well, do they have telehealth or in-person care? The alternative is nothing. And if we can't get the medicine on the end of their dirt road where they don't have a car, their dealer will. So my simple request is just that, is that it's recognized that as a telehealth provider, we're real people. If there's a mess we need to help somebody clean up, we can be called. There's a phone number on the prescription of who prescribed your medicine. You can get a hold of us. We deeply care about our patients. And I trained in the opioid epidemic in some of the crises of the mid-2000s. I nearly left medicine because of how awful it was. Watched how my fellow colleagues, myself and my staff, were treated in a small town that was getting eaten alive by the opioid epidemic. I do not want that to happen because of buprenorphine I'm prescribing. But buprenorphine and telehealth together are part of the solution to that. And we want to be held accountable in the same way any brick and mortar clinic would be. Thank you.
Thank you. If I could ask just a couple follow-up questions. You talked about you are using unique ways to check toxicology, the toxicology. Could you just elaborate a little bit?
Yeah, we use an oral swab. We use saliva. And there's a whole system that I actually don't do it. It's our great staff that does it so they could speak to but there's a number, and they watch the patient put it in, they read the number, they seal it. It can be, and you can tell if they unseal it. And so it's an observed screen that then gets overnighted and gone to the lab. What's beautiful about it is that most urine screens are not observed, and this is observed. It's online. Is there a way to cheat it? I've watched ways to cheat every drug test we've been able to come up with, sadly. But it's pretty good. It's not bulletproof, but it's very good.
Could you elaborate a little bit, whether it's your organization or what you've seen in terms of is your prescribing done by physicians? Is it done by nurse practitioners, physician assistants? And there have been some commenters who suggested, potentially requiring additional training for some prescribers that aren't physicians or family docs. Just curious on if you could expand.
We're primarily a nurse practitioner practice. I think so we need to normalize the prescription of this medicine, and it's totally appropriate that my colleagues who are nurse practitioners and physician's assistants are providing this care. If we didn't have that, access would be terrible. And we could spend a half-day seminar on this, what appropriate collaboration and supervision looks like is, and that's very near and dear to my heart, much longer answer, but I think that's where the money is.
Last question, you talked about just buprenorphine generally. How do we get this to everyone? You asked the question, but you didn't answer it. So can I, in 1 or 2 minutes, ask you to offer your...
So what I was trying, so I do think telehealth is part of the solution. We remove as many barriers as possible is how we do it. What I was, the message I was intending to send is I think the burden of proof is on the people, I don't want to personalize this. The burden of proof, show me, if we have something that's 8-fold effective in mortality, show me that telehealth is dangerous. I'm being a little provocative by saying, please don't show me that telehealth needs to be safe. I'm flipping the burden of proof a little bit. And I don't entirely believe in that, by the way. It's more of a rhetorical question, because I do think we have a burden of doing no harm in everything we do. So I'm not being overly provocative. How do we get it to people? We train more people. We normalize it. We normalize. One concerning statistic I've heard a few times today is a red flag that a certain clinician prescribes so much, X number of % of their prescriptions is buprenorphine. I will save you the time. It's almost all of my prescriptions because that's what I do for a living. We would never tell an oncologist that they're prescribing too much chemotherapy. Why is all your medicine chemotherapy? Why is all the pulmonologists why is it all asthma and COPD medicine? That's not a thing. Of course, most of my prescriptions are going to be for buprenorphine because that's what we do. That's my specialty. We need to normalize it, like any other chronic disease.
I would just like to get your thoughts on. We had a presenter yesterday. It was in Tennessee, and he said it had been. He couldn't even think of the last time he had someone that came in just suffering from OUD because of the methamphetamine, because of benzos. Are you seeing that?
Yes, we do. And it's a good example of some of what I think is appropriate and inappropriate for telehealth. The benzodiazepine use disorder is very difficult to manage by telehealth because with withdrawal you have to check blood pressure, you have to check pulse. There are certain things, and by the way, in 2 years, if there's a way, there are ways to do that by telehealth now, but if they're more available and they're easy to do, I would retract that statement. Right now, the way we do not, so if somebody says, oh yeah, and I find that, look, there's benzodiazepines in your talk screen, I would love to take care of you on a telehealth platform, but that's not what we're gonna be able to help you with. Methamphetamine's different. I wish we had better medicine for methamphetamine use disorder. We have some, they're not the best. And we need to be with people on the journey while they're on their journey with meth while we're keeping them safe on opiates. So those people we do retain in our practice. We see them a lot more often. We see them weekly instead of, they don't get to that month-long thing. Thank you.
And we now have commenter number 8 to the stage. Thank you very much.
DEA Administrator Milgram and Deputy Assistant Administrator Provoznik, thank you for the opportunity to testify today. My name is Dr. Hallie Chrisman, HALLEY-CRISSMAN. I use she, her pronouns. I serve as the Associate Medical Director and Director of Gender Affirming Care at Planned Parenthood of Michigan, an affiliate of Planned Parenthood Federation of America. Planned Parenthood is the leading advocate for high-quality, affordable sexual and reproductive health care for all people in the United States. As healthcare providers, Planned Parenthood's nearly 600 affiliate health centers prescribe patients medication as medically necessary and appropriate, which includes controlled substances like testosterone, which will be my focus today. I am a board-certified obstetrician gynecologist, and I have a master's degree in public health. In my role at Planned Parenthood, I get to oversee gender-affirming hormone care for more than 2,200 patients across 13 health centers and via telemedicine. My clinical work focuses on reproductive and sexual health care for gender-diverse people. I've published numerous peer-reviewed journal articles related to gender diversity and gender-affirming reproductive health care, and I've trained more than 20 advanced practice providers in gender-affirming hormone care. I also serve as adjunct clinical assistant professor in obstetrics and gynecology at the University of Michigan, where I see patients both in person and via telemedicine for gender-affirming care. Today, I am proud to testify about the critical need for testosterone to remain available through a telemedicine prescription without an in-person evaluation requirement. Gender-affirming care refers to a range of services provided to support transgender, non-binary, and gender-diverse people. It includes care related to physical, mental, social health needs, and well-being, all affirming a patient's gender identity. Medically necessary gender-affirming care includes mental health counseling, non-medical social transition, and most relevant for the DEA's work, gender-affirming hormone therapy. Gender-affirming hormone therapy, as well as other forms of gender-affirming care, is the evidence-based standard of care. Appropriate recipients of this necessary form of treatment are identified on a case-by-case basis with their healthcare provider. Gender-affirming care is life-saving care. It has implications that are incredible for mental health and well-being. My clinical experience has made it clear that testosterone can be safely and effectively prescribed via telemedicine, and that this path is essential for patient access. Since the DEA waived an in-person evaluation requirement, providers have developed thorough standards and protocols for attuned and high-quality medical care via telemedicine. Every day via telemedicine, patients and providers expect and build full patient-provider relationships. Telemedicine has proven essential for my patients to access gender-affirming care, many of whom began treatment during the COVID pandemic because telemedicine care made it possible for them to access care. In Michigan, where I practice, telemedicine has played a crucial role in expanding access to gender-affirming care, allowing the concentration of healthcare providers in the southern portion of the state to expand their reach to the northern portion. Requiring even a single in-person visit to access testosterone could mean that many of my patients will be prevented from accessing gender-affirming therapy, a potentially catastrophic result for their health and lives. In the months since the declaration of the end of the public health emergency, which should be a good thing, I have fielded countless calls and messages from patients worried they won't be able to travel for an in-person visit, terrified they will lose access to the care that has been a literal lifeline. Gender-affirming hormone care with testosterone is incredibly well-suited to telemedicine care. Testosterone is a non-narcotic Schedule III substance for which safety and diversionary concerns are notably low. Testosterone is not an addictive substance. In my years as a clinician, I have not seen a patient abuse or intentionally misuse prescribed testosterone. I understand the DEA's interest in ensuring there is a diversionary framework in place, but an in-person evaluation is neither the only nor the best solution. Moreover, the DEA's diversionary goals are advanced by providers reviewing recent PDMP or Prescription Drug Monitoring Program data. For testosterone, blood labs are typically the only important information for safely initiating and monitoring testosterone therapy that cannot be obtained directly during a telemedicine visit. Thankfully, healthcare providers are well accustomed with protocols for having patients obtain labs locally and are not reliant on labs obtained concurrently with an in-person visit. Instead of an in-person visit requirement, healthcare providers can instead order blood labs, which can be obtained at a healthcare facility or commercial lab local to the patient, and then transmitted to the ordering provider for review. These avenues for obtaining lab results allow healthcare providers prescribing testosterone to make their own assessment of the patient while being equipped with information about the patient's physical state via review of pertinent lab results. An in-person evaluation for testosterone requirement is medically unnecessary and burdens patients that would be disproportionately impacting individuals affected by systemic and institutional forms of oppression. Planned Parenthood centers, including those I oversee, provide inclusionary care, but many members of the LGBTQ+ communities, particularly trans and non-binary individuals, face discrimination and forms of violence when seeking health care, including misgendering, invasive unnecessary questioning, unwanted touching, and abusive language. A recent survey found that approximately half of transgender and non-binary respondents reported having at least one of these kinds of negative experiences with a doctor or healthcare provider in the last year. A particularly vitriolic discourse now runs rampant in some state governments and local jurisdictions, compounding longstanding access issues. Gender-affirming care is health care. It has clear support from all major American medical professional associations, including the American Medical Association and American Pediatric Association. But numerous states have severely restricted access to gender-affirming care. In 2022, state legislatures across the country introduced more than 100 anti-trans bills. In 2023, there's been a dramatic expansion of anti-trans legislation. Almost 500 anti-LGBTQ+ bills have been introduced in state legislatures this year. Roughly 130 of these target trans health care. These bills are extremely harmful. People of all gender identities deserve civil and human rights. I shouldn't have to say that, including the right to high quality, affordable, and non-judgmental health care. These bans actively impede access to care and stigmatize those who seek it. In this climate, telemedicine access for testosterone is essential. An in-person evaluation or a referral for one is for many people simply unattainable. A return to in-person evaluation requirements would interrupt patient care and for some present insurmountable barriers to accessing prescriptions for testosterone that they need, particularly for patients who are young, live in rural areas, are working to make ends meet, or live at the intersection of multiple of these. With respect to practitioner record keeping, providers' record-keeping obligations and practices are already robust. For provider privacy and personal security, and because records could be misused by hostile lawmakers to target individuals who've obtained gender-affirming hormone therapy, providers should be required to document only their city and state during a telemedicine appointment and maintain any records at the registered location of their dispensing registration. Planned Parenthood's concern about the risk of entities hostile to gender-affirming hormone therapy misusing prescribing records to criminalize patients and or providers like me who receive and provide this medically necessary care extends to all data keeping requirements, as well as to the DEA's consideration of a special registration. Planned Parenthood strongly urges the DEA to exercise caution in deciding how to implement such a registration. It is imperative that it be maximally protective of patient and provider safety and privacy and does not burden access to care. In sum, Because testosterone prescriptions made via telemedicine are safe and effective, because an in-person evaluation requirement would severely interrupt care for patients who need access to testosterone, and because there are alternatives that the DEA could utilize to ensure a satisfactory diversionary framework, Planned Parenthood strongly advocates for the DEA to permit telemedicine prescription of testosterone without burdening patients with an in-person evaluation. Thank you for the opportunity to testify.
Good question, and I'm going to ask you a general question that a number of folks raised the same issue yesterday around provider privacy and not wanting to have the specific address. You just mentioned, I think you mentioned city and state. What about zip code? Like what, if you could just sort of expand a little bit about where you think that line might be, that'd be helpful.
I don't know if I can comment on a specific line in the sand without seeing something written. And I know we would be happy to submit written comments. But what I would say is if the DEA thinks that a national registry is necessary or that collecting more details of location are necessary, we urge adequate protections of this highly sensitive medical information and urge cognizance, in particular in relation to gender-affirming care, of the hostility and real dangers that patients and providers may face if this information is in hostile hands, including of regulators who are anti-trans. Thanks.
And we now have commenter number 9 coming to the podium.
Good afternoon. My name is Jessica Rigsby. That's Jessicca, last name Rigsby, Rigsby. And I am the head of legal and compliance at Ophelia Health. I'm a licensed attorney, as well as being certified in healthcare compliance. I've been in the OUD treatment space for many years, initially with a typical brick and mortar clinic organization, and now in telemedicine. I can say from experience, the additional privacy and ease of access in telemedicine helps patients get in and stay in care well beyond what is standard in-person treatment. I'd like to start by thanking the DEA for this opportunity to speak about the special registration. I'm here today on behalf of Ophelia, our clinicians, and our patients. Ophelia provides medical treatment via telemedicine for opioid use disorder and mental health care under a team-based medication and counseling model. Our mission is to make high-quality, evidence-based MOUD care safe, affordable, and accessible to all. I want to highlight that it's important to understand that we believe telemedicine is a complement to, and not a total replacement for, in-person care. Telemedicine adds to the treatment ecosystem, improving access, outcomes, satisfaction, and reducing costs. During the last 3 years, Ophelia has navigated through state and federal level regulations and PHE flexibilities, and at the same time proven that telemedicine MOUD care is safe and effective. We've seen telemedicine decrease the treatment gap, which is one of the main drivers of the epidemic of opioid overdose deaths. More than 80% of our patients had not received any type of OUD treatment before coming to us, demonstrating how clearly telemedicine creates access. We've also spent time publishing studies to demonstrate and share what we've learned, including a study that showed high treatment retention rates irrespective of patient geography and race or ethnicity. We've learned that 80% of patients stay in care for at least 6 months if they can use their in-network insurance benefits, but that some insurance plans are skeptical of contracting with us due to the uncertain future of telemedicine controlled substance prescribing. I won't spend my time today reiterating all of the wonderful points others have made at these sessions about how much telemedicine increases access, reaches populations otherwise unserved, et cetera, et cetera. Ophelia submitted a lengthy comment in March to the proposed rules, which outlines all of that. Instead, I'm going to talk about some basic best practices for telemedicine in general, follow up with best practices specific to telemedicine MOUD, discuss a few misconceptions about at-home urine drug screens, and also some truths about buprenorphine. All telemedicine prescribers, regardless of the conditions that they treat, should be adhering to basic best practices and regulatory requirements. This is a non-exhaustive list, but maintaining clinical licensure and, of course, DEA registration in good standing, compliance with all state, federal laws, including state-level controlled substance registrations, and any collaborative or supervision requirements for nurse practitioners and physician assistants. We should all be abiding by clinically appropriate policies and procedures specific to the care that we provide, and we should have established processes for assessing patients for appropriateness for telemedicine care, and be prepared to refer patients to in-person care, either initially or at any point during treatment when it becomes indicated clinically or becomes patient preference. We should have protocols for detecting and managing emergencies and protecting confidentiality. Telemedicine providers should be willing to participate with major insurance plans, including public and private payers. And we should all be addressing commonly occurring medical and psychiatric comorbidities. Clinicians prescribing buprenorphine for OUD via telemedicine should additionally be adhering to requirements like using synchronous audiovisual clinical visits as the standard, diversion prevention and detection protocols that include the use of all the tools available to us, things like PD&P checks before every single prescription, real-time UDS screening protocols, film or pill counts when clinically indicated, and advising patients on safe medication storage. Clinical leadership and supervision should be done by qualified addiction medicine or psychiatry specialists and should conduct internal clinical oversight like clinical case reviews and clinical support for monitoring controlled substance prescribing. Clinical models should include minimum standards of care, such as obtaining patient medical and psychiatric history, collaborating with outside providers like patient's primary care physician or other specialty care providers, real-time audiovisual clinical evaluation, starting with higher frequency and decreasing as patients stabilize, with a minimum of at least one clinical visit per month per patient. A treatment agreement with the patient and a documented clinical treatment plan, as well as periodic UDS and maintaining comprehensive medical records of treatment and medication accounting. OUD telemedicine clinicians should build referral and consultation relationships with treatment programs in the communities where their patients live. These relationships should include primary care and specialty care services, as well as other in-person OUD care options, including OTPs and residential addiction care. Often OUD care is a patient's first meaningful connection with healthcare, and we should be using this opportunity to connect them to other crucial preventative and comprehensive healthcare. Before I move on, a few things about diversion management. We prevent diversion the same way in-person care does. By establishing good relationships with patients, assessing their progress, and maintaining open communication. All that in partnership with regular, documented PD&P review and urine drug screens. The topic of urine drug screens has come up a number of times in these sessions. Anyone who has been in healthcare for any time at all has heard a wild story about a patient's attempt at faking a UDS. Interestingly, though, a 2022 study found very low rates of falsification of urine drug screens among patients with OUD receiving treatment via telemedicine. Our own study at Ophelia, which included close to 3,400 patients, which were monitored for at least 180 days, was recently published in JAMA. It showed that it is feasible to conduct regular urine drug screening in a remote setting with very low rates of unexpected results, such as being negative for buprenorphine or positive for other opioids. At-home UDS kits are simple to use, screen for multiple substances, include built-in tampering prevention, such as temperature readings and indicators of adulteration. These results are easy for clinicians to obtain and view during a clinical audio-visual visit with the patient. Every Ophelia patient has at least one, if not more, sealed UDS kits on hand at all times. We can also refer patients to local labs, such as Quest, if more sensitive or comprehensive testing is indicated. We have detailed UDS protocols and keep extensive records on the collection and results of each UDS. Now on to buprenorphine. We understand the DEA's concern about diversion in telehealth in general, but buprenorphine is different from other controlled substances. It has a much different risk to benefit ratio. Buprenorphine isn't a recreational drug. It blocks the opioid receptors in the brain, minimizing cravings associated with OUD, without producing a high when used as prescribed. Studies have repeatedly found that diverted buprenorphine is an attempt by individuals to initiate OUD treatment they don't have access to on their own. Studies also indicate that 70 to 90+% of people who use illicit Suboxone report using it to prevent cravings and withdrawal. A recent study by health authorities found that despite increases in buprenorphine prescribing after the onset of COVID, there was not a correlating association with the prevalence of buprenorphine among overdose victims. This study replicated findings from an earlier study in New York City showing that buprenorphine was incredibly uncommon in the toxicology reports for overdose victims, speaking to its risk protective profile. Our data speaks for itself. At Ophelia, we've treated over 10,000 patients during the past 3 years, with only 10 overdose-related deaths reported to us. That is 1/10%, and is well below the incredibly high rate of mortality otherwise observed among individuals with OUD, which is typically 1 to 2% annually, possibly higher at this point with dangerous fentanyl exposure. Many individuals treated with buprenorphine are alive today because they were able to access this treatment via telehealth. We firmly believe that every patient in care is one less person seeking diverted opioids. We reduce diversion not just among our patients with our internal monitoring protocols, but by reducing the number of customers in the market for diverted opioids. SAMHSA's own publications show that patients who discontinue OUD medication generally return to illicit opioid use within just a few weeks or months. Low barrier access to quality buprenorphine care prevents diversion. One final point, the opioid PHE is still in effect and has been for 6 years. We would ask the DEA to repeat the flexibilities it extended to all controlled substances during the COVID PHE to buprenorphine under the opioid PHE for as long as it lasts. In closing, we are directly addressing the root cause of the opioid PHE, one patient at a time. We like to think we are your partners in the fight against diversion and not the cause of it. On behalf of our current patients and all those still looking for an answer to their OUD, thank you for taking the time to listen to our recommendations. We appreciate your care and your attention.
Pause here just for a sec. Do they have questions? We're good?
No, they're good.
Okay, thank you. I'm going to ask commenter number 10 to pause before coming up. We're going to take just a 5-minute leg stretch break. So we will come back, let's see, at 2:55. Thank you.
This is the DEA Telemedicine listening session. We're currently on a break. Thank you for joining us. This is the DEA Telemedicine Listening Session. Thank you for joining us. We're currently on a break.
Okay, we'll go ahead and get started. I am happy to call commenter number 10 to the podium. Hey, Marcella, say your name and spell it, and you got you. Thank you.
Marcelo Fernandez Vina, Marcelo Fernandez -Vina. I'm with the Pew Charitable Trusts. Good afternoon. I'm Marcelo H. Fernandez Vina, appearing today on behalf of the Pew Charitable Trust Substance Use Prevention and Treatment Initiative. Pew works with states and at the federal level to address the nation's opioid overdose crisis by developing solutions that improve access to timely, comprehensive, evidence-based, and sustainable treatment for opioid use disorder. The Pew Charitable Trust, through its Substance Use Prevention and Treatment Initiative, recommends that the pandemic flexibilities allowing for buprenorphine prescribing by all DEA registered practitioners via telehealth without an in-person requirement be kept in place permanently. Overdose deaths have reached unprecedented levels in recent years, with over 100,000 overdose deaths occurring in 2022, the majority of which involved opioids. In light of the public health crisis we face, access to buprenorphine should not be restricted. Therefore, Pew urges the DEA to take steps to maintain access to buprenorphine in order to curb the overdose epidemic. Allowing healthcare providers to prescribe buprenorphine remotely during the pandemic helped more patients start and stay in treatment without increasing overdose deaths. The pandemic telehealth flexibilities helped veterans, people experiencing homelessness, individuals involved in the criminal justice system, those living in rural areas, and racial and ethnic minorities access buprenorphine via telehealth with audio-only visits, helping many of these patients access care. Allowing buprenorphine to be prescribed via telehealth decreases challenges associated with transportation and geography and helps patients with work and childcare responsibilities. Telehealth improved access to care for rural and hard-to-reach populations, reduced wait times, and worked around challenges with childcare, work, transportation, and stigma. Under DEA's pandemic flexibilities, buprenorphine was safely and effectively prescribed via telemedicine and reached more people, including people that traditionally face challenges accessing buprenorphine by centering patient access, comfort, and empowerment, and reducing barriers to treatment. DEA's pandemic flexibilities improved access to buprenorphine by allowing patients to start life-saving medication via telehealth without having to see a provider in person. In multiple studies, both patients and prescribers report positive experiences with telehealth for buprenorphine prescribing, including a greater sense of ease, flexibility, and autonomy for patients. Earlier this year, researchers at Harvard Medical School found that providing OUD care via telehealth may be comparable to in-person OUD care, and no evidence indicates that telehealth for OUD care is unsafe or overused. A study published in JAMA Psychiatry found that Medicare beneficiaries who received telehealth services related to OUD were more likely to stay on medication and less likely to experience an overdose. Similarly, Veterans Health Administration patients using telehealth for buprenorphine treatment were more likely to stay in treatment than patients being seen in person. Based on this information, additional requirements for prescribing buprenorphine via telehealth, including a special registration, impose arbitrary, non-evidence-based barriers to life-saving treatment. During the pandemic, all prescribers were able to utilize telehealth with no special registration requirement. Given the administration's and this agency's commitment to prioritizing meaningful interventions that address substance use disorders, DEA should carefully consider the effect special registrations can have on restricting access to buprenorphine treatment. Both DEA and the National Institute on Drug Abuse agree that increased buprenorphine prescribing decreases diversion. DEA has previously stated that it's actually lack of access to buprenorphine that drives buprenorphine diversion, and that increasing access to medication may be an effective way to prevent diversion. The National Institute on Drug Abuse has also stated that buprenorphine access as buprenorphine access increases, buprenorphine diversion decreases. An assessment of telehealth's impact on adverse outcomes found no data indicating evidence of increased diversion for patients receiving care via telehealth. Rather, studies found that virtual buprenorphine access led to few adverse events. There are existing robust safeguards in place to prevent buprenorphine misuse and diversion. Prescribers of controlled substances are already registered with the DEA and licensed through their state boards, meaning they have to meet specific standards of healthcare delivery to practice or they risk losing their license. In addition, most states require prescribers to use their prescription drug monitoring programs, or PDMPs, to track prescriptions for controlled substances in Schedules 2 through 5. Most PDMPs update their data on a daily or weekly basis and participate in interstate data sharing. In our view, additional data collection by DEA is unnecessary. Under DEA's pandemic flexibilities, buprenorphine was safely and effectively prescribed via audio-only and audio-video telemedicine without additional data collection measures, and prescribers in the future should not be subject to additional arbitrary requirements which could reduce access to life-saving medication. I'd also like to note that CMS already collects data on the use of telehealth by requiring Medicare practitioners to use the modifier for telehealth claims, and Medicaid and other insurers track telehealth claims. Buprenorphine is extremely safe, and overdose risk on buprenorphine is extremely low, as the drug has a ceiling effect, meaning its effects will plateau and not increase even with repeat dosing. It's notable that as buprenorphine prescribing increased during COVID, overdose deaths involving buprenorphine did not increase. The evidence is clear. Buprenorphine is safe, effective, and saves lives. Buprenorphine access plays a vital role in reducing buprenorphine diversion, and there are major benefits to public health and safety that the pandemic flexibilities provided to patients with OUD. The Pew Charitable Trust strongly recommends that the pandemic flexibilities allowing for buprenorphine prescribing by all DEA registered practitioners via telehealth without an in-person requirement be kept in place permanently. Given the overwhelming evidence base in support of our recommendations today, Pew urges the DEA to finalize a rule for telehealth prescribing of buprenorphine without an in-person requirement as soon as possible. To avoid reductions in access to treatment during the rulemaking process, we urge DEA to extend the existing temporary rule or use the already designated opioid public health emergency to keep the pandemic flexibilities in place for buprenorphine prescribing via telehealth. Thank you for the opportunity to offer comments on behalf of the Pew Charitable Trust and for your attention to these matters today. I'm happy to respond to any questions you may have.
Okay. No questions? Okay, thank you. And we are now calling commenter number 11. Thank you so much. Don't forget name, affiliation, spelling. Thank you.
He just told me not to worry about the 10-minute time limit, just do what I need to do and go as long as I can. Everybody here has been extremely courteous for the last 2 days, but it is the driest event I've ever attended in my life. I mean, honestly, the people that's been here yesterday and today are changing the world. It's an emotional thing, and I hope I can hold it together. All of my friends and family are watching, but I'm passionate. I've heard of doctors, lawyers, scientists, professors from Yale, Harvard, Johns Hopkins University, pharmaceutical representatives from the government. And I'll tell you who I am. I am rural America. My name is Dan Golden, Golden. For further clarification, I'm commenter number 11, which is ELEVEN. See, we're smiling and having fun. In all seriousness, I do represent rural America. We have East Coast telepsychiatry, and our provider is Amy Farr. She's a 29-year nurse practitioner who is passionate about the care of her patients. When the telehealth thing went in chaos at the end of March, we panicked. Everything that we owned, we put into doing a telehealth business to provide care for people. And people don't understand, in rural America, the numbers are different. Washington, D.C. and the DEA is not America. America that I live in Northumberland County, Virginia. There are 2 stoplights in the whole county. 23 miles apart. And those two stoplights are twice as many items that there are providers. There are not two providers in the county. The closest hospital does not accept psychiatric patients because they have no psychiatric doctor that works at VCU Tappahannock Hospital in Virginia. So obviously the statistics are there. Rural America needs help. Rural America needs telehealth. They don't need restrictions that punish the patient. Basic statistics that I want to try to cover everything. I want to talk like the Micro Machine guy from the commercials back in the 80s. By 2034, the American medical colleges report there will be a shortage of 124,000 providers in the United States. Another statistic that I don't know that people are aware of, telehealth visits increased from 2019 to 840,000 to 52.7 million telehealth visits in 1 year, from 2019 to 2020. According to the United States Census Bureau, in the last 4 weeks, this survey was done in February. In the last 4 weeks, 23% of all adult Americans had attended a telehealth appointment. Many hospitals have no psychiatric providers. There are providers available, but the average wait time, according to a study from Virginia Tech School of Medicine and Medscape in the state of Virginia, only 18% of psychiatrists were available to see new patients. The median wait time was 67 days for inpatient appointments, yet only 23 for telepsychiatry. The crime factors, if the patients don't get the medicine from providers, we prescribe a lot of Adderall, Concerta, Vyvanse for people with ADHD and important matters. I can walk out probably on the corner of this property and get that item from illegal drug sellers. So we need to ensure that people are taken care of by proper care. And in 2008, the White House mandated that the DEA create special exemptions. 15 years later, we're sitting here trying to do so. And one thing that I want to make very clear, I think the DEA has liked having everyone here yesterday and today and getting this input and hopefully doing a lot of the work for them, because they can't think of all of the things that providers, prescribers, doctors, pharmacists deal with on a day-to-day basis. I think one thing that is very important is that the DEA needs to build a team of providers, pharmacists, and any other key parties to meet virtually maybe every 90 days or 6 months, because the decisions that you make in the next few months are going to be outdated in 2 years. Technology is going faster than we can even fathom. One thing that I do think is important that's not been addressed, I do think a telehealth visit should be done by a person, not an AI bot, because that is going to be a factor probably within 9 months, sooner, or may already be happening. So those are things that need to be looked at. The PMP awareness program, everybody has mentioned it, and I'm going to strive that that thing is crucial. We had a patient last fall. She scheduled an appointment the 1st of November. She was determined to have ADHD. She was prescribed Adderall. She returned for a follow-up visit a month later. She had obtained the exact same medication from 4 more providers, all within a 30-day period. The PMP system needs to be federal. If it's state level, they're all going to have their own quirks and additions. It needs to be one shot. So when I click in and the guy just moved from San Antonio, Texas to Lottsburg, Virginia, I can see what he got over the last year, what medications he's been on. And talk about flagging providers and pharmacists. The patients need flagged. If I put in a prescription, or our provider, Amy Farr, puts in a prescription for a patient and they pick up that medication, the problem is with PMP that's not been mentioned by anybody, it is hugely flawed. And if the government picks up on the PMP today, it will be an utter failure, because pharmacists put on the fill date of a medication. If I prescribe, my buddy Pierre gets prescribed maybe Vyvanse, and we send in the prescription electronically today, and the pharmacist has time to fill it this evening, he enters into PMP that it's filled, and he hangs it on the rack in the little plastic bag for people to come and pick up. Well, Pierre may not pick his medicine up till next Monday or Tuesday. So then when he comes for his follow-up in 28 to 31 days, you know, he's getting his medication a week early. So now he's got extra Adderall laying around, or he can sell those 7 pills, or he's not taking the medication properly. Every patient that we see, and I do think this should be something added on to providers, every patient, every visit, there should be a PMP check pulled and stuck in their file for review. For the simple fact that it prevents people from drug shopping. It prevents pharmacists from giving out the pills, you know, even though somebody's gotten 4 different prescriptions for Adderall 20 milligram in the last 3 weeks. And something else, the lady from Medicaid yesterday mentioned there's fraud being done in the EPCS. A federal PMP program would also eliminate that, because Amy Farr can say, I didn't prescribe these 3 medicines, so she can report, hey, somebody's hacked my account or done whatever. You know, there's multiple safeguards that can take place there. And, you know, this is a common sense thing to me. That's why I'm glad I'm here and I don't have all those degrees. I'm rural. I'm the country dude. I built decks for 25 years. I have no medical background until my wife decides we need to open a practice to take care of people. She's been a nurse practitioner for 29 years and is passionate. And the rules that are currently in place could devastate every penny we've ever spent. And I know these rules are changing. That's why we're here. It's just a matter of lining up the dots and getting things done. So we're thankful. And this gentleman mentioned early was, you know, the grandfather thing. It's already in effect. You know, don't worry about your current patients. The current wording when you pull up on the DEA website is that exemption was placed from March until this November, but for previous existing patients, it's active until 2024. That needs to change immediately. Any pre-existing patients and cases, the wording needs to say when somebody Googles it, they are grandfathered forever. You know, there's no reason that you've have a patient coming to us for the last 2.5 years, and in November 2024, I have to say, I'm sorry I can no longer prescribe your medication. I'm sorry about your anxiety. What's going to happen to a person with anxiety if they can't find a provider within 2 months and they can't get to an office? It provides undue stress. So the people that we have, they don't need to be limited to 2024. The patients we have now, we have a right to keep those patients, and they have a right to choose and leave if they want to. Driver's license, state ID, or a passport. In my opinion, if a person is getting a controlled substance, they have to produce that to the provider, and they have to produce it every time they pick up a prescription. It's not Motrin, it's not you know, some simple cold remedy. It is a controlled substance. Video visits versus telephone. A video visit should be mandatory for at least the first visit. Put eyes on the person so when the driver's license comes in, you at least know you're talking to the same person. After that, you go to a telephone. The same care can be given on a telephone. We don't like to do it. We require video visits. On rare occasion, we do the telephone just for the fact you can lay eyes on the people. They may tell you they're perfectly fine, but they may have tears coming down their face. They may have physical problems. They may have meth marks, you know, things that people need to see. So video is important. If it's done by telephone only, that's okay. But the first visit, I think we need to establish, yeah, this is John Doe, because that's what his driver's license says. Let me see if I have anything else. I know my time is ticking. The DEA is worried about the future. The future happened 2 years ago when the United States was put into a pandemic. So it's too late. You need to fix these rules now, and you need to ensure that you do things to continuously change things as they need change. Don't wait 20 years to address this topic again, because it's not happening. You will be left behind in a technological dust. So with that, I'd like to thank everybody for my time and putting up with my passion.
Pause here for just a second, just in the event that you have any questions.
Good.
Nope. Thank you, sir. Bye. Appreciate you. Okay, we are now welcoming commenter number 12 to the stage. Thank you. Name, affiliation, and spell your name, please.
Yeah.
Thank you.
So, thank you to the commenter number 11, given the time that we're at. So, my name is Dr. Kevin Simon, Kevin, K-E-V-I-N, Simon, S-I-M-O-N, and I am here from the city of Boston. I appreciate the Pew acknowledging a study that's from our group with regards to opioid use and telehealth. So I'm here today representing dual roles. I serve as this first Chief Behavioral Health Officer for the city of Boston, and professionally I am one of these rare child and adolescent and adult psychiatrists. I'm also board certified in addiction medicine and operate or work through the Adolescent Substance Use and Addiction Program, also known as ASAP, at Boston Children's Hospital. So I get to care for families, youth. A mother emailed me today with regards to her son, who's 14, met him when he was 12. And he had to go to the ED, in part because he used to be in DYS, or Department of Youth Services, so Juvenile Justice Service, got discharged on Friday, and today is all of Wednesday or Thursday. And at school, he was vomiting, in part because he's engaged in Percocet and other opioids. So telehealth is critical. It is a life-saving measure that we've demonstrated through our group, particularly when we're thinking about adolescents, and this hasn't yet been mentioned, and I'm going off the cuff and not really with my remarks here. In reference, for all the adult patients that we're talking about, 90% began their substance engagement before 18. So in terms of who we really should be trying to target, it's those who are adolescents. And the reality is adolescence has prolonged itself over time because socially, you get to be on your parents' insurance until 26. Average age of marriage back in when my parents got married, well, yes, it might have been 21. That's not the case anymore. So in terms of how do we ensure appropriateness of care, well, we do it with our group. We meet, yes, with the patient, but adolescents don't really like to share information all that much, but because they're under 21 or really under 18, we also meet with their parents or their guardian. And the reality is you have access to collateral information to ensure the patient that you may not be able to see visually, somebody else is able to see that person. So I want to talk about two fictitious but real patients, Anna from rural America and Jason from urban America. The reality is Anna, although she's not from a city like DC or New York, she's not safeguarded by having a condition like autism spectrum disorder, which 50 to 60% of patients with autism have ADHD. Patients that have ADHD, 20 to 30% of them have autism. They're gonna need medication. If we're talking about Jason, who lives in, let's say, East Brunswick, it's really close to Jersey, it's really close to New York City, but complicated factors, neighborhood disorder, make it such that he's experiencing life, mental health condition, substance use engagement, pre-addiction. The fact of the matter is, unless we're providing telehealth services, we're gonna miss a whole host of people, and it's actively happening now. So of that 90% of adults that began engagement with substances before 18, the truth of the matter is less than 15%, the data here depends on the source, but less than 15% actually receive evidence-informed treatment. Now, there's treatment, but then there's evidence-informed treatment. The fact of the matter is, telehealth allows clinicians to reach that population. So, I wholly understand that the DEA is required to do safeguards and practice and want to ensure that there's no diversion. I practice cautiously myself. But the truth is, as that gentleman said, you probably should convene a group. And I get that we have a 2-day convening here, but I know that there's, I know that there's working groups that are in the DEA and health fraud division that are trying to find bad actors, because the reality is there are often bad actors, but just trying to take away something that you've given to many patients, it's just, the genie's out the bottle. It's hard to put the genie back in. So in reference to proposed rules, the registration, I know it's been on the books, it has yet to actually been enacted. You have a whole host of people who are prescribing actively. To try to get them to actively do 8-hour training will be difficult. We've seen removal of the X waiver has not shifted the amount of people who actually should be prescribing buprenorphine. I prescribe it, but literally I have colleagues in hospitals that'll say, well, I'm not comfortable. So I'm not really sure what adding an additional layer of mandate or requirement is going to do. It's probably just going to stem people from actually engaging. So the reality is that, as the person, I think, commenter 10, so research from our group identified that those that have substance use problems, mental health conditions, particularly that are adolescent, actually do engage pretty well with regards to telehealth services. And the key part about our study was they were very willing to come in after being established vis-a-vis telehealth. So I don't necessarily think you need a mandate, because the reality is if you're with a provider that you trust and it's been 3 months or 6 months, and you make the suggestion to come in, very likely that they will actually come in. And if we're talking about those who are minors, if they can't come in, well, some guardian can come in because they're potentially not unhoused. So when we're thinking about this idea of the rural and the urban individual, the truth is you have tools that are at your disposal. Yes, the PDMP, you don't have current engagement with it. I'm sure that would be very difficult to do for the fact that it's in technically I think 49 states. I'm not sure if Missouri has added it yet. So the truth is this is a very complicated issue. I greatly appreciate that you're attempting to resolve some of the issues. I do think if we're going to go back to the 2008 and try to do a special registration, there has to be some subset of criteria in terms of who can prescribe. Again, there's less than 8,000 child psychiatrists. I'm one of them. If you want, you should take a photo of me because there's just not many of us. But we're not the only ones who can prescribe stimulants. We're not the only ones who can prescribe buprenorphine. But again, even those that can aren't. In terms of setting some kind of standardization, so just like every year for every state that I'm licensed in, I have to get a renewal. So if you're going to have a special registration, there needs to be a renewal process. And physicians and prescribers are already used to a renewal process because we all have to do that for the respective states that we're in. In terms of routine monitoring, I just don't know what the jurisdiction is of the DEA in terms of trying to set up some regular monitoring. The current monitoring that I think happens is there's somebody who's a good whistleblower and says, hey, something's going on here, and then you guys go in and search. But I don't know that you have the capacity to set up some kind of monitoring system. But that would be ideal. And then again, this tech integration, it doesn't yet exist, but if it could, that also would be ideal. So I know you've listened to many people, and I can see my time's winding down. The reality is the special registration, that would be great. But the problem that we're trying to figure out exceeds 2 days of listening. And those of us at Boston Children's Hospital Association, all of the advocacy groups that you heard from would gladly partner in trying to figure it out. But literally, as I'm standing here, there's a patient of mine that I'll see vis-a-vis telehealth tomorrow because I'm here and they're in Massachusetts. So it's going to be very hard to curtail something that you've given to millions of people over the last couple of years. So I'll stop there and just thank you for the opportunity to be engaging here.
Any questions? No? Thank you, Dr. Smith. Appreciate it. Okay, we are going to be bringing up our 13th commenter. I will say that we had up to 14 today, and I don't believe that Dr. Kolodny is here yet, if at all. So I will say that assuming that we have no one after commenter 13, we will then go back to one in-virtual commenter who could not join us in the morning, and that will be our last presentation for the day. So commenter number 13, welcome to the stage.
Presbyopia, so I can't work off of a small device. I bring up a laptop.
Absolutely.
And I've used like 16 point, and hopefully
Wonderful.
I can capture this. Thank you. Good afternoon. I'm Dr. Shirley Ruddock, S-H-I-R-L-E-Y, Ruddock, R-E-D-D-O-C-H. A board-certified pediatrician and pediatric hematologist-oncologist with 40 years' experience in direct patient care and his pediatric residency and pediatric hematology-oncology fellowship program faculty. Currently, at the latter part of my professional life, I have a part-time faculty appointment in pediatrics at Johns Hopkins, continuing appointment at Johns Hopkins School of Medicine, where I serve as clinical teaching attending in the Children's Hospital. Thank you for the opportunity to speak at this DEA listening session centered on the subject of telemedicine, prescribing of controlled substances, and the role or necessity of in-person medical evaluations by the prescriber. Today, I speak to you as an individual concerned physician and not representative of Johns Hopkins or any other healthcare organization or general medical or specialty associations. Although, like other presenters, I am a member of several specialty organizations. To name some, the American Academy of Pediatrics, the American Society of Pediatric Hematology Oncology, and the American Medical Association. Before specific comments on the current question, I'd like to give you a little bit more of my background, experience, and observations over time in medicine. I started my residency training in pediatrics in 1981, entering the Army on active duty after completing medical school in the civilian sector. Subsequently, I served as a general pediatrician in an Army community hospital and clinic before doing my pediatric hematology oncology fellowship training at then Walter Reed Army Medical Center. Following fellowship, I served as Peds HEMOC and on pediatric residency faculty at 2 other Army medical centers before transferring to this area, Fort Meade, Maryland, in healthcare admin role as Deputy Commander for Clinical Services at Kimbrough. I then returned to Walter Reed, first leading the Department of Health Plan Management, then returning to full-time Peds HEMOC practice and on pediatric residency and fellowship program faculty with clinical faculty appointment at Uniformed Services University of Health Sciences. Those were my first 24 years of practice and were within the military healthcare system, which I understood the beneficiary population well, as a member with a family in that beneficiary community as well as a physician. Given the size of our program and resource allocations, we all practiced in the inpatient and outpatient setting, so knew our patients in both those environments. In those years prior to formal telehealth programs, all care was considered in person, though telephonic communications were frequently made and documented, with only occasional non-controlled substance prescriptions associated with a telephonic communication with a patient, again, already seen and followed by the physician or service team of physicians. Medical students, it's important to know, medical students, residents, fellows in training at this time, understood and were engaged in the continuity of care between inpatient and outpatient settings and direct communication between primary care and specialty care. Leaving practice in the military healthcare system and affiliating with Johns Hopkins pediatric hematology now 18 years ago, I'm feeling older by the minute as I read this, I recognize the challenges of much larger socioeconomically diverse patient referral populations, not only geographically spread, but often with primary care or other specialty care outside of the Hopkins medical system. As with any such system, there are those patients who are well known to the service, but many others with only infrequent encounters within the system, and sometimes more in the emergency room or inpatient setting than out. Various insurance coverages and or no coverage further separated accessible or covered sites and sources of care and services. Establishment of a sophisticated electronic record system with expanding capabilities helped to connect different electronic record sources via the health information exchange in the state, and PDMP helped in monitoring certain controlled substance prescriptions. But still, the weaknesses interpreting that information were often revealed when patients were seen for their in-person visits. Although I cannot speak to all areas of Hopkins medicine, as I recall now, outpatient telehealth visits were just being implemented by my service colleagues at or around the time the COVID-19 pandemic hit. My activity was inpatient care at that time, but our service case management discussions ensured awareness of in-person and telehealth encounters, and often covered opioid use and pain management of conditions like sickle cell disease with complications involving acute and chronic pain. Formal video visits with ability to prescribe controlled medications have greatly facilitated continuity of care of established patients, but periodic in-person care, advisedly outpatient, but also evident with episodic inpatient care managed by the same service team, is still the practice. We should also remember that during this time, these last few years, with severe restrictions placed on outpatient in-person visits and limitations set on who and how many members of a care team and which members could even see patients on the inpatient services directly, and the level of PPE required for a provider to wear to see patients in either setting, medical trainees, students, residents, fellows were getting a very different learning experience from those prior to the pandemic years. And immersed in such removed evaluations and care of patients with their rapidly developing facility and comfort with telehealth care. It is my concern that this may heighten risk, just in general, for overuse of, overconfidence in, or misapplication of telehealth, with emphasis or preference for virtual care on part of practitioners as well as patients. Following my further conversations with physicians across the country, to include hospital-centered and community-based hospice and palliative care programs, psychiatry, and a chronic opioid use pain management program, and listening to presentations last day, my considered conclusion is there still should be an inpatient evaluation that is proximate in time and related to an initial telehealth visit for prescribing controlled substances. And ideally, that visit should be with that prescriber. Ongoing telehealth prescribing of ongoing telehealth prescribing of controlled substances by that prescriber should be within appropriate disease and condition management that warrants such prescribing, with the telehealth prescriber trained and appropriately certified in such fields as substance use disorder or medical specialties covering specific diseases, conditions requiring frequent or chronic medications in the schedules of controlled substance, or hospice and palliative care medicine. The telehealth prescriber must be licensed for telehealth in the state where the patient resides, And if by chance is so geographically removed from the patient that the prescriber cannot see the patient in person, there should be a primary referring practitioner in room with the patient, simultaneously communicating on video visit platform with the consulting provider specialist. Documentation of such a visit must be adequately reflected in both the primary provider and consulting provider's record system. If the disease condition management with prescribing of controlled substances is continued by the remote-only telehealth consultant specialist, there should be a documented primary care or referring provider relationship established to facilitate future tandem video visits in person as initially established. If the primary care provider with ability to do periodic in-person evaluations assumes responsibility for prescribing of controlled substances following the specialty consulting provider care plan, there should be follow-up recommendations with frequency and whether in-person or telehealth acceptable follow-up is stated and understood. If the consultant specialist who is accessible only via video visits assumes continuing prescribing responsibility, it should be so documented. Exceptions to this process, that was my bell. Okay, I kept hearing. Okay. Exceptions to this process can be codified, outlined in policy, established state by state, with involvement of the state practitioners' licensing boards, with consideration of the healthcare needs of the population, with attention to the underserved. States should be cautious about permitting any out-of-state practitioners' organizations only licensed for telehealth in the state to develop an independent telehealth practice independent of any in-person direct health care service or working with such a direct health care service residing within the state, as this may directly compete with and undermine the work of such similar services that may exist within the state that I heard alluded to in visits, in presentations last day. And with the in-state services appropriately and serving the state's populace. Quality of care, adherence to care outcome measures should be tied to telehealth only exception programs, as well as those that offer in-person visit capability. This again requires additional insights as may be ascertained from state medical societies, licensing board, health departments, nonprofit healthcare organization, independent practices, and FQHCs within the state. Codification or policy at federal level for exceptions to visits may also need to be reviewed regarding programs that serve DoD and federal institutions. All controlled substances at high risk for diversion, abuse, or overprescribing should be reported on a standard PDMP platform that can communicate across state lines, essentially nationally, as many others have recommended. And with such tremendous input and some concrete recommendations that have been presented by in the trenches providers in these 2 days who have identified specific risk mitigation measures to be taken, including qualifications of providers, teleprescribing, and particularly in psychiatric and behavioral health only, telehealth only practice, would suggest the DEA specifically look at those recommendations made. But I would also recommend reassessing adequacy of education on controlled substance use and prescribing for practitioners and pharmacists in telehealth environments, and a more robust, standardized education surrounding prescribing of controlled substances in various settings, patient settings, electronic prescribing, and telehealth platforms be formally incorporated in and across all graduate medical education before upcoming physician transitions from care oversight within residency programs to widely varying and increasingly narrower focus of independent clinical practice settings. This speaks to not just specializations in care, but sites of care like ambulatory only, hospital only, emergency medicine practices, where one can easily narrow patient care focus to their environment of care and can decrease attention to patients' overall health care, which requires access to other settings of care. And believe it or not, my final concern to raise is actually the primary one that brought this listening session to my attention. It is that of legal lethal dose prescribing of single or combination of medications prescription that can involve one or more controlled substances or clearly off-label toxic use of non-controlled medications. This type of prescribing was legalized in several states via end-of-life option or medical aid in dying legislation and offers the most protection of those prescribers, no protection of patients or transparency to family and other non-medical aid in dying involved providers. There's likewise no real monitoring of adherence to minimal documentation requirements, thresholds for investigation, and no consistent way to identify if and or when the prescription is taken, as patients could have died of underlying qualifying diagnosis before taking medication, delayed taking prescription, gotten better, changed their minds. There are no particular skills or training required of a prescriber to prescribe a killing dose of any medication. One would say this is not chronic care or continuing medication risk, but telehealth visits in lieu of in-person for this prescription consultation promotes too easily obtained prescriptions, no assurance of any care for the patient by the prescriber who is not otherwise involved in the patient's care if the patient chooses not to take or delays taking medication. Such telehealth providers must be licensed in the state of the patient's residence and should not be able to violate visit prescribing rules of that legislation if not enacted in the patient's state. There is ample opportunity to obscure illegal prescribing, as in illegal in certain states, as in still the majority of states. As I am not engaged in telehealth directly, with associated controlled substance prescribing, this particular DEA request for input in listening sessions did not actually get my attention or many of the other people I consulted who practice good medicine in their fields with good documentation, telehealth, and prescribing. But my antenna went up when I heard that Death with Dignity sent out alerts to their followers requesting and eliciting approximately 10,000 comments by their count of your 38,000 comments to the DEA supporting telehealth-only prescribing. I realize then that there's an underappreciated risk that lay in this ongoing expansion of telehealth. So I bring that to your attention. And subsequently, I was sent a copy of a letter that I think may have already been sent to you from concerned organizations opposing assisted suicide. So this is always on people's minds. And the potential of this kind of use of telehealth actually further undermines reliance and trust of those providers involved in care of hospice and palliative care. And one final comment, speaking to what a recent prior speaker just raised, is that the specter of AI as threat to integrity of telehealth. I think that is very real. And with so much imitation, you don't know sometimes that, will it get so good that you won't even know if you've got a real patient in front of you, not just the provider, but the patient. So we need to move away from dependency on this or any other singular encounter type, as we may need to pivot, as we've had to so many times in medicine. Thank you very much for your listening.
Any questions? Okay, thank you so much. Okay, and we will now, like I said earlier, go to our virtual presenter number 13. Thank you.
Hello, my name is Dr. Sarah Spencer, Sarah, and I'm representing myself today. I'm an employee of the Ninilchik Tribal Council and the head addiction medicine consultant for the Alaska Native Tribal Health Consortium. I'm here today to speak on telemedicine regulations of buprenorphine for the treatment of opioid use disorder and to speak against the requirement for an in-person visit. I'm a board-certified addiction medicine physician, fellow of the American Society of Addiction Medicine, who has provided care for patients with opioid use disorder in rural Alaska for 13 years. And I've been offering telemedicine for OUD for years prior to COVID. To remind you of the vastness of Alaska, we are, of course, more than twice the size of Texas, and there are over 200 Alaska Native villages spread over 660,000 square miles, most of them off the road system. I work in tribal health, and I'm one of the only addiction medicine specialists in the state that provides treatment of OUD via telemedicine for any Alaska Native person, regardless of tribal affiliation. I work on the rural southern Kenai Peninsula, and I'm the only addiction medicine specialist in our 25,000 square mile borough. The next nearest addiction medicine specialist and the nearest methadone clinic are over 200 miles away in Anchorage. In 2021, Alaska suffered the greatest increase nationwide in our overdose death rates, with fentanyl-related deaths up 150%. And the overdose rates in Alaska Native people are triple that of white Alaskans. In fact, Indigenous Americans nationwide are among the populations with the highest overdose death rates. Buprenorphine has been shown to reduce mortality related to OUD by over 60%. However, many remote areas in Alaska still have no local access to this medication. Most of the 170 tribal village clinics are off the road system, meaning patients can only get in and out via boat or plane, and they are staffed only by community health aid practitioners, with licensed providers such as doctors, NPs, or PAs visiting just a few times a month or sometimes less than once a month. And there are huge tribal regions such as the 115,000 square mile Arctic Slope and Norton Sound region that have 0 prescribers of buprenorphine. Historically, fear and stigma around diversion or misuse of sublingual buprenorphine, as well as the challenges in monitoring the use of this medication in remote areas, have caused many rural tribal clinics to shy away from offering this medication altogether. Monthly long-acting injectable buprenorphine has less stigma surrounding its use, and it could potentially dramatically expand treatment availability. But unfortunately, due to DEA restrictions, it cannot be shipped to a remote village clinic staffed only by a community health aid practitioner because it can only be shipped to clinics that have a resident DEA licensed provider. So unfortunately, this medication is also not accessible to patients living in remote Native villages. Most of the tribal organizations who do offer MOUD offer medication options that can be limited, and many only provide in-person care, and they require patients to travel from their remote home villages to the hub clinic to attend in-person visits. I am one of only 2 physicians in the state of Alaska with the Indian Health Service Internet Eligible Controlled Substance Provider exemption to allow for buprenorphine prescribing without an in-person visit. However, that exemption requires that the patient be present at the remote village clinic site to receive services. And merely obtaining this certification does not ensure the cooperation of the distant tribal health organization. And I have personally seen multiple incidences of patients refuse telemedicine access from their home tribal clinic to access buprenorphine therapy. Within these large tribal health organizations exist many individual tribal clinics, all with different tribal councils, different administrations, and some have policies against providing buprenorphine therapy, and they may refuse to collaborate with an outside clinic offering the service and refuse to host telemedicine specialty consultation appointments originating at their clinic. Patients may also be unable or unwilling to access care through their local clinic due to very legitimate privacy concerns in these very small villages. Since the Internet Eligible Controlled Substance Provider exemption does not apply to patients being seen in their homes, I cannot provide treatment to Native beneficiaries living in these underserved areas or to non-Native patients living in any remote Native village if an in-person visit is required. The Alaska Native Medical Center in Anchorage is the specialty care referral hub of the state for Native beneficiaries, but it does not have an addiction medicine department and has no system in place to offer buprenorphine therapy via telemedicine for remote patients. So uninsured Native beneficiaries living in remote villages lacking a buprenorphine prescriber locally essentially have no access to this treatment. When patients do need to travel for in-person visits, the costs can be astronomical. The cost for a patient to get from a remote village in northwestern Alaska to my specialty clinic for an in-person visit could easily exceed $1,500. Even for non-natives who live on the Kenai Peninsula, the majority live more than 20 miles from my clinic, and the nearest pharmacy is 35 miles from my clinic. 90% of our patients have Medicaid, and most either don't own an operational vehicle or they don't have a valid driver's license, and even if they do have those things, many may not be able to afford the gas for the 70-plus mile round trip. These patient costs were not adequately accounted for in your cost impact analysis of this regulation. Our clinic is the only one on the Kenai Peninsula of Alaska offering low threshold buprenorphine treatment. We offer telemedicine to all patients for their intake appointment, and this has dramatically reduced our no-show rates. It also allows us to offer a more flexible open access schedule so patients can get same-day telemedicine appointments for urgent care. To assist with medication monitoring, patients who are not able to travel to the clinic may choose to participate in drug testing through local clinic labs or through mail-order oral fluid tests with virtually observed collection. We utilize random medication counts conducted by video when needed, and patients also have the option of demonstrating medication compliance through video directly observed therapy when appropriate for their care plan. Most of our patients do a mix of telemedicine and in-person care, and this flexibility has greatly increased our ability to support our patients' retention and treatment, as well as improve patient satisfaction. Most of our patients self-refer for monthly injectable buprenorphine. However, it's not unusual for patients to have to take sublingual buprenorphine for more than a month prior to being able to travel to the office for their first injection. In fact, I've had a patient that had to drive 250 miles one way to get his first injection. Also, there are many patients who struggle and fall in and out of care in those first few weeks and months, and they may need multiple follow-up telemedicine appointments over several months to motivate and enable them to attend that first in-person visit. Buprenorphine interruption, such as would occur if a patient had not attended their first in-person visit by the end of 30 days, is dangerous. After buprenorphine discontinuation, 50% of people return to use within a month, and 1 in 20 experience an overdose event the following year. The Ryan-Hunt Act was intended to reduce the inappropriate prescribing of medications such as prescription opioids that increase the risk of overdose. Buprenorphine, however, is a very safe medication since it does not induce respiratory depression, and it dramatically reduces mortality risk in patients with OUD. So it's not surprising that overdoses involving buprenorphine did not increase during the pandemic, despite its increased availability via telemedicine. And in August 22, JAMA Psychiatry study looking at 175,000 Medicare beneficiaries who received telemedicine for buprenorphine therapy, the use of telemedicine to access buprenorphine was associated with a reduced overdose risk and improvement in treatment retention. Additionally, data that is gathered from in-person visits, such as urine drug testing, has not been shown to improve treatment outcomes or to reduce diversion. In summary, requiring an in-person visit to prescribe more than 30 days of buprenorphine for OUD treatment will only result in further exacerbating the already disproportionately reduced access to treatment suffered by our most vulnerable and most affected populations, including Alaska Natives and American Indians, low-income patients, and those living in rural areas. The arbitrary decision to require an in-person visit at 30 days has no basis in evidence to improve patient outcomes, while we have strong evidence that uninterrupted access to medication for OUD is critical to reduce mortality. I strongly believe that the requirement for in-person visits for buprenorphine prescribing will do more harm than good and recommend it to be removed from the proposed telemedicine regulation. Thank you for the opportunity to speak today, and I welcome any questions.
Okay. Thank you, Dr. Spencer. My understanding is there are no follow-up questions, so I want to thank you for participating and for being our last presenter. And I will say that by purposes of concluding remarks, again, thank you for everyone who took time out of your busy schedules to be here on either one day or 2 days. I want to give a special thanks to Administrator Milgram and Assistant Administrator Provoznik for taking time out of their schedules to also listen. I think and I hope it demonstrates to you and the public and those that are watching us virtually that we really do care about trying to get this right. So with that, I will say again, thank you, safe travels, and enjoy the rest of your week.